When shall I share the YouTube link with my classmates? So those who are not there, because I've been getting a lot of requests. So can I do that?
Is the YouTube link generated, Kritika? 1 second, Bharti.
Yes, I'm just sending it.
Yeah, please send it to me. We can just start
Okay.
forwarding it. Ma'am, should we put it on the group as well?
Takreem, please start the video. Gatika, please start the video. We have too many people over here. We cannot have 100 participants. Just 1 second, stop the recording. Start the recording. Students, please leave. We cannot have so many students here. We need speakers to join. Gargi, please ask your students to leave and join YouTube. I'll send the YouTube link. Gargi, please ask.
Yes, ma'am. Yes, ma'am. The link has been sent, ma'am. They will join there soon.
Takreem, you'll need to remove some students from here. 10 of them right away. Speakers will not be able to join.
Ma'am, I'm on it. I'm doing that only.
Please bring it down to 80. You can start the video, guys. Katika, please start the video.
हर दिल की अपनी ताल है, अपना ही एक राग है। हर दिल की अपनी धड़कने, अपनी ही एक आग है। जज्बात पिघले पिघले है तो क्यों ना हो, ख्यालात बहके बहके है तो क्यों ना हो। हर दिल धड़कने दो,
Ma'am, we are
दिल धड़कने दो, दिल धड़कने दो। Na na na, give me some sunshine, give me some rain, give me another chance. I wanna grow up once again. Give me some sunshine, give me some rain, give me another chance. I wanna grow up once again. Na 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 na. Na 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 जो दिल से लगे उसे कह दो हाय 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 हाय, जो दिल ना लगे उसे कह दो बाय 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 बाय। आने दो दिल में आ जाने दो, कह दो मुस्कुराहट को हाय 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 हाय। जाने दो दिल से चले जाने दो, कह दो घबरा को bye 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 bye. Love you zindagi, love you zindagi, love you zindagi.
How to love myself first. And it was worth every part. You matter, you are so loved, and you're not a background character in other people's stories. You are the main character of your own life, and your story is not over yet.
हर दिल की अपनी ताल है, अपना ही एक राग है। हर दिल की अपनी धड़कने, अपनी ही एक आग है। जज्बात पिघले पिघले है तो क्यों ना हो, ख्यालात बहके बहके है तो क्यों ना हो। हर दिल धड़कने दो, दिल धड़कने दो, दिल धड़कने दो। Give me some sunshine, give me some rain, give me another chance. I wanna grow up once again. Give me some sunshine, give me some rain, give me another chance. I wanna grow up once again. Na 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 na. Na 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 जो दिल से लगे उसे कह दो हाय 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 हाय, जो दिल ना लगे उसे कह दो बाय 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 बाय। आने दो दिल में आ जाने दो, कह दो मुस्कुराहट को हाय 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 हाय। जाने दो दिल से चले जाने दो, कह दो घबराहट को बाय 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 बाय। Love you zindagi, love you zindagi, love you zindagi.
How to love myself first. And it was worth every part. You matter, you are so loved, and you're not a background character in other people's stories. You are the main character of your own life, and your story is not over yet.
हर दिल की अपनी ताल है, अपना ही एक राग है। हर दिल की अपनी धड़कने, अपनी ही एक आग है। जज्बात पिघले पिघले है तो क्यों ना हो, ख्यालात बहके बहके है तो क्यों ना हो। हर दिल धड़कने दो, दिल धड़कने दो, दिल धड़कने दो। Give me some sunshine, give me some rain, give me another chance. I wanna grow up once again. Give me some sunshine, give me some rain, give me another chance. I wanna grow up once again.
A very good afternoon to one and all present here today. I, Takreem Malik, welcome you all to this intercollegiate webinar to create awareness on the World Suicide Prevention Day. Let's connect to protect. Organized by the Department of Psychology, RD and SH National College and SWA Science College in collaboration with WICCI Public Service Council Maharashtra and SNDT University affiliated Maniben Nanavati Women's College Department of Psychology. We are extremely honored to have several esteemed speakers here with us today. We are also more than gratified to announce that for this event, we have an extensive participation of over 300 students from Jai Hind College, KC College, MD Shah Mahila College of Arts and Commerce, MMK College of Commerce and Economics, Sophia College, Bhavans College, Tulani College of Commerce, from Mumbai, Orai, Gadchiroli, Lucknow, and from various other colleges and universities from several cities across India. I would like to begin this webinar by taking this opportunity to share a quote by Matt Haig, a widely popular author who himself had a fierce battle with depression and suicidal ideations, which led him to write one of his best-selling books, his memoir titled Reasons to Stay Alive. I quote, "Soak up the views, take in the bad weather and the good weather. You are not the storm." In a world altered by the COVID-19 pandemic, which is one of the greatest storms that humanity has ever faced in this century, International Association for Suicide Prevention said that as psychosocial implications of social distancing, quarantines, and other restrictions become clear, mental health will become a global priority. Today, on the occasion of World Suicide Prevention Day, we take this opportunity to raise awareness, start the discussion, and extend a helping hand through this webinar. As the theme suggests, it is important to realize that reaching out is not weak. We as humans are not meant to walk through life alone, handling everything that gets thrown our way all by ourselves. We're social creatures, and with that comes the need for someone to lean on once in a while. A best friend, a partner, family members. Maybe all of these people are who you lean on when in times of need. Staying in touch with those around you can not only help strengthen bonds, alleviate moods, but can also potentially avert a crisis and save a life. You may never know who can find support and protection in your simple connection. With that being said, I would now like to begin our webinar by thanking our principal in charge, Dr. Neha Chaktiani, and Hyderabad Sindh National Collegiate Board and Head of Department of Psychology, Dr. Meghna Basu Thakur, as no program is complete without her tremendous effort and support, because of whom this event has become possible and who has given all of us an opportunity to learn and create awareness about suicide. I would also like to thank Dr. Ratri Trivedi, Principal and Head of Department of English at Maniben Nanavati Women's College, and Dr. Celia Chettiar, Head of Department, and Dr. Anuja Deshpande, Faculty and PG Coordinator in the Department of Psychology at MNWC. We thank you for your immense support and valuable guidance. Our first speaker for the day, Dr. Harish Shetty, is one of the most well-known psychiatrists in Mumbai, with an experience of over 3 decades. Consultant psychiatrist and psychotherapist, he is a member of Indian Medical Association and Indian Psychiatric Society. He is also present on the advisory board of top counseling and wellness centers. He has worked with victims of disaster and communal rights across the country and has contributed extensively in school mental health. Recently, he has been appointed as a member of National Testing Agency by Union Cabinet Minister on behalf of HRD Ministry. His topic for today's session, #YouMakeTodayBetter, suggests that we as a society need to understand and work on geriatric population, which is an important part of our community as much as any other individual from any demographic population. Without further ado, I would like to invite Dr. Shetty to take this event forward. Thank you.
Good afternoon, everybody. And I'm sure that you can see my slides. Can you, Takri? Okay. Good afternoon, everybody who have joined. Tomorrow is the World Suicide Prevention Day, and we have been in great difficulties in the last 2 years. Congratulations for all those young boys and girls and students who are listening to their parents and staying indoors for a very, very long time, albeit with a little confrontation and anger. My best wishes for all those who have recovered from COVID and are doing fine, and those who are still struggling, that they should recover much faster, and my best wishes for them. My condolences to all those who have lost loved ones, friends, acquaintances across the last 2 years. When you talk about the elderly, first understand what are your attitudes towards the elderly in your own family. I think that is something which is extremely important, extremely important. And if your attitudes towards the elderly, if your attitude towards the elderly is of contempt or irritability, I think the best geriatric psychology or geriatric psychiatry is learned when you live with elderly people, your grandparents, and that really is a laboratory for understanding mental health in the geriatric population. They are our tomorrows, and we are their yesterdays. This one sentence I learned from my school in psychiatry, that when an elderly person talks about severe anxiety, always suspect depression and screen for depression. Now, let me share with all psychologists and all students here and all qualified psychologists and psychiatrists and others. Do not be ashamed to inquire about suicidal thoughts among everybody you see in your clinic or in your practice or those who are down. Now, I will tell you why. Well, anywhere I go, speaking about depression or mental health, when I ask this question, have you ever attempted self-harm? Or have you ever been thinking about self-harm? A lot of people put their hands up. The point I want to make is, people are willing to talk, but we are not willing to ask the right questions at the right time. There's a lot of hesitation among physicians, non-psychologists, non-psychiatrists in asking this question to the patients who come to them for diabetes, depression, heart illnesses, etc. Because very few understand that comorbid depression is extremely common with chronic illnesses. Now, generally, when there's some stigma, you don't inquire. You elicit. You elicit about smoking, you elicit about alcohol. In the past, we used to elicit about mood changes and depression by asking them questions which are peripheral and then slowly going to the center, which means we would say whether you feel good about today, and then slowly go and ask them questions about harming themselves. But today is a day when suicide is not in the realm of elicitation, but it's in the realm of inquiry, and that is very important. And before I start, I pay my obeisance to two great mental professionals, Patanjali and Gautam Buddha, who gave us both Vipassana, which is mindfulness, and yoga. Now, when you see all this, these are the thoughts which you need to really actually look at, and they are: number one, when somebody suddenly wants to make a will, be very suspicious. If there are existential thoughts, what is the point in living? My son is settled, my daughter is now settled. There's no point in living at all. I'm doing extremely well. And these are the signs which you need to look at and inquire about: mood changes, depressive thoughts, and suicidal ideations. Listlessness in COVID. I don't feel like going out. I don't feel like doing anything at all. I feel like staying indoors, and I feel very, very down. It's more of fatigue and listlessness because of being indoors for a very long time. And then you need to really screen for depression by asking them other questions: whether you feel hopeless, whether you feel worthless, whether you feel very lazy, whether you feel extremely exhausted, whether you feel like crying, whether you feel very agitated, whether you feel as it's good being dead than alive, whether your concentration is affected, and all the symptoms. Loneliness is also correlated to depression and suicidal thoughts, which means loneliness can actually can actually lead to depression, but at the same time, depressed adults or elderly people would remain withdrawn. I still remember this man and woman who would not come down in their building to be with others in the evening. And somebody called me up and said, "There's something wrong with these guys. They're mentally ill." I said, "I don't know, but if they're not come down and they're still outside and they're not coming down and mixing with others, go and knock at the door." And somebody said, "No, we will not do it. It's their space. It's their life. It's their choice." When you are a mental professional, when you are a mental health missionary, it's not their choice. You have to encroach their space. You have to break the Lakshman Rekha. You have to do Sima Ullanghana and check what has happened. And when they actually went inside, they found they have not eaten for the last 4 days. They were very, very emaciated. They were dehydrated and they were depressed. They were taken to hospital and then treated by a psychologist and a psychiatrist, and they felt good. Comorbid illness, 40% of those who have depression, kidney disease, stroke, and any chronic illness have associated depression. There are so many instances where elderly people have jumped down from hospitals, and it's extremely important for us to understand that they need to be treated. Loss of spouse, loss of wife is also a predictor for self-harm. And when somebody loses a spouse, especially the wife survive the loss of husband, but men do not survive as much as others. And loss of spouse is also a very important aspect when you actually screen patients of depression. And if there is something which says that he has lost his spouse, please screen for depression, and that is important. Suicide pattern. There are many couples who say we don't want to live. There's no point in living. We have done our job well, and there's no point in living. And these are the patients also. Now, hopelessness and hope. They're the two poles. And hopelessness is a sine qua non sign of depression. And generally, when people speak about hopelessness, when they go for walks with other retired people, other senior citizens, and they appear very clingy. These are also signs where somebody may be depressed and maybe contemplating suicide. Staying indoors also is a very important sign. Increased alcohol intake, again, is a sign that one has to be careful with elderly. Globalization alienation, which means our kids are in USA. We send them to USA. We want them to get educated. We wanted them to get educated. But then they got jobs there, and then they're there, and they do not want to come this side. And then you want them here, but you can't tell them that you have to come here. You want them to prosper, but you still feel very lonely. And globalization alienation has been one of the most important reasons for the same. Now, there are other very, very subtle signs. People come for frequent checkups, and they have multiple somatic complaints. And this is also one of the most important subtle signs, and they need to be screened. And here, what is very important is non-psychiatric consultants, non-psychologist consultants who are probably doing angel therapy, tarot cards, they all land up there. And also doctors who do not have exposure to mental health are also people where most of the elderly land up with depression. Avoiding going to temples, mosques, churches. I don't want to go to the mass. I actually don't want to visit the temple. I've not gone to the temple for a long time. Or excessive, staying inside the temple. Sudden increase in God. Sudden increase in Adhyatma is also a very important sign. We need to be very careful. Giving away things, it's supposed to be things, THINGS, is also a very important. I still remember the elderly man who suddenly gave away his flat to his nephew, his nephew, and people were very surprised. This fellow was very stingy all his life, close to not sharing his wealth. And once he gave his flat, people felt he really has changed. His heart is open and become very generous. But he committed suicide after 2 months. Falling prey to cheats. I still remember a chartered accountant, elderly man, chartered accountant, extremely good. Somehow he was gaming all the time because he was sad and depressed. He was avoiding people, and he suddenly got into this African gang. We cheated him with more than 15 lakhs, and he just did not know what happened. When he came to me, I found that he had a logical mind, rational thought, but still he was very vulnerable. So, and when we screened him, he was very, very depressed. Sudden, huge donations. Again, very important sign which you need to look at. Now, let's look at the suicide victims as far as statistics are concerned. 2019, the latest NCRB survey for India says that 8,049 and 2,647 men and women committed suicide. So it's basically, elderly suicide is basically a men's domain. It's more men. Even if you see the figures between 45 and 60, again, men are approximately 4 times more prone to attempt self-harm and successfully commit suicide. And so this is a very important piece of data from NCRB India. Again, if you look at this data also, we need to look at why people in UP, Jammu and Kashmir, Nagaland, Manipur, and Bihar have very low frequency of suicide, low incidence of suicide. And people would say that maybe the reporting is bad. I would like to think otherwise. I would like to think that probably there is some social support system, in spite of poverty, in spite of violence, in spite of so many other things, that keeps the society bonded and the incidence of suicide is less. Maybe a PhD student should send her PhD guy should send his or her PhD student or an MPhil student or an MA student for a small study in some of the villages or some of the places where these figures actually emerges. Again, the latest figures available in India. So Bihar, Manipur, Nagaland, Uttar Pradesh, Jammu and Kashmir, and Lakshadweep have very low incidence of suicide, much less than the national average of 10.4. In fact, UP is 2.4, the national average is 10.4. And this is a very significant indicator for us to check why elderly people also commit less suicide. Another study, 2019, 488 elderly people, and it's a multicentric study conducted by Dr. Sandeep Dover from PGI. They show that one out of 4 with depression, elderly depressed, have suicidal thoughts. One out of 6 have attempted suicide across their lifetime, and 1 out of 10 have attempted suicide in the recent past. Even increase of alcohol is also a very important indicator, and these are some figures for the country. Number of alcohol has increased. Family problems are 1 out of 3 people who harm themselves with suicide in the country are supposed to have family problems, and probably family problems. There's a lot of real estate issues among the elderly. In fact, in big cities, people having 2 children want to buy 2 houses while selling 1 house, and it's not possible as of now because the cost of housing across different suburbs, at least in the city of Bombay, same. Earlier from Girgaon you could come to Andheri, and from Andheri you could go to Malad. Now you can't go to Malad from Andheri. The costs are the same. So real estate costs also cause a lot of family problems and a lot of angst, which could lead to depression. I would say that here also family problems could be a very important cause for the elderly to be depressed. Now, let me say, now what are the things by which we need to do for depression, elderly depressed? Social support is one of the most important indicators to beat depression when it's mild. And without a family history of depression, without a past episode of depression, just social support. I still remember this couple who shifted from Khetwadi to Powai, and they phoned me up and said, we need friends. I said, of course. And I checked out with 2 or 3 groups who would walk together or meet together. And I really connected them. They were not in contact with anybody for 1 year. Immediately they flowered and they felt nice. So social support is one of the most important antidotes for elderly depressed. At the same time, I would say there's a lot of literature coming from yoga. Now, yoga, you can't introduce yoga straight to the elderly depressed. If yoga is introduced much early in life, they practice across life. And a lot of elderly people who do yoga, meet people and exercise, have found themselves to remain healthy across time. A lot of elderly people are very reluctant to take psychological treatment. They are very reluctant to take psychiatric care also. When a physician quietly asks them, will you actually take a small antidepressant, or will you go to a counselor? I would recommend. They say, no. हाँ तकलीफ है, मुझे अच्छा नहीं लगता है. My son has not sent me enough money from USA. In fact, he stops, and I feel very sad. I feel very let down. I feel very betrayed, and I feel very sad. But time is the best healer. समय से सब कुछ ठीक होता है. And what is very important for mental professionals to understand, the time is not always the best healer. Time does not heal. In this 21st century, when 1 out of 7 Indians are mentally ill, 20 crore Indians are mentally ill, based on the figures which have been released by Government of India, Ministry of Welfare, just before the epidemic. In a country where 1 out of 4 Indians harm themselves and kill themselves, and they are daily wage laborers. In such a country as of now, When there's so much angst, when there's so much COVID, when there's so much globalization, which has alienated people completely, we need to be extremely careful, and we should actually confront this sentence, which is a narrative among a lot of people that time is not always the best healer. With this, I would like to say, my dear friends, do not overestimate the resilience of the elderly. Do not think that because they have really taken care of you, they have been fantastic across time, they've been through several hurdles, they've shown their mettle across several crises. Do not overestimate this resilience at all. And that is so important, because those who harm themselves at this age, when they decide they would want to harm themselves, they are very successful. I'll share a story. A doctor's father was under my care long, long ago. And actually, he would say, I'm very anxious. And I would tell his son that he is not anxious, depressed, he might harm himself. And he would say, no, I'm not suicidal. And when you have to really look at, understand the subtle sense of suicide, when you ask this question, are you suicidal? If there's a pause, the person is suicidal. If the person fails to make eye contact, drops the eye contact for a couple of seconds and then says, no, he's suicidal. When a patient says, when a person says, don't ask me such stupid question, most of the times he or she could be suicidal. So it's extremely important for you to understand that, and this man actually killed himself under a train and showed it as if it was an accident. So you need to really not overestimate the power of resilience. You need to understand that when somebody elderly in your family or outside, you do not have to show them the same feeling and same awe that, I'm trying to tell you that you're depressed, please take help. No, if you have a lot of awe for the elderly in your family, you would not be able to successfully actually help them negotiate depression and take treatment. All psychological therapies are as important as we all understand, and psychiatric care is very important when the depression is very severe and not amenable at all. With this, I would like to share this last slide saying thank you. This is Sindhutai Sakpal. Meaning in life is a very powerful antidote for depression in the elderly. And if people find meaning in life, people find meaning in life by probably donating something to charity, but probably going and working in an NGO, probably doing something in service of the country or the community or the caste, etc. And they find this to be very useful. Lastly, my dear friends, there was a Jain elderly man who was extremely depressed because he could not go to his market, and his son would say, well, everything is closed, father, please don't go. He would say, tum humko kaam pe nahi bhejega to I will not survive and I will not live. And the best thing what his son did is requested him to do a lot of COVID work where he could help a lot of people get oxygen and medicines with this. He really found his bearings and improved. So meaning in life is also a very powerful antidote session. With this, thank you, Takreem. Thank you, Meghna, and all the best.
Thank you so much, sir. That was absolutely a lot of knowledge, a lot of input, a lot of data, and I think it's very important for our audience present here and on live YouTube to understand, suicide from the perspective of the geriatric population. We generally focus a lot on suicide and the adolescent and marital issues, etc., but we don't really talk on the geriatric population. And so thank you so much for taking time out. So there are a couple of questions from the audience. There's one question: how do we address the reluctance to approach mental health services when it comes to the geriatric population, our own dadis, nanis?
Yeah, absolutely. There are 5 or 6 ways by which you can do it. So many of them are in touch with their family doctor, and the family doctor, they have faith. They have been through a physician or a family doctor or a gynecologist, and they have absolute faith. These doctors can be a vehicle for psychiatric treatment and also to induce them to take psychological treatment as necessary. That's number one. Number two, remember, everybody on this earth has somebody whom he or she listens to. There's somebody, man rakhi jo hai, and man rakhi jo hai means I will do what he says. Once at least I will go, and that is something which also. Number three, also there are a lot of elderly people who are taking treatment, and when these elderly people who are taking treatment speak to them, and things are much better. Number four, surreptitiously, if a family physician can provide a tablet, which if required, and treat the elderly patient without his knowledge, perfectly all right. Also, a family physician or a doctor or a good friend is able to provide supportive counseling, not CBT, not REBT, not interpersonal therapy, not DPT, supportive counseling, where we can sit down and talk. That also would be great. Fifth, which is very, very important, is a lot of elderly are very, very cognitive in their mind. And if you show them a lot of literature and if they're convinced, then they take treatment. Lastly, when nothing fails, rock the boat. And I tell children of elderly people that you should rock the boat and say that you don't love me, my dear father. This is what you are doing. You don't love me, my grandfather, and do everything that is required to really take this person to a doctor and treat the person and see that they stay alive.
Thank you, sir. Thank you, doctor. There's one more question. How to help prevent the symptoms from arising in the future in our grandparents?
Absolutely, I think that's a fantastic question. And number one is see to it that they are physically active. In COVID, everybody would tell them to baitho na tum kuch mat karo. And sitting in front of the TV for 12 to 14 hours also causes a lot of listlessness, fatigue, and exhaustion, and also mood changes. So even in the era of COVID, it's important that they do little activity with the house if they're active. Little activities, folding the clothes, walking up and down, cutting the vegetables, or doing something or other. That is number one. Number two, my teacher, Dr. N.S. Vaya, who's no more, late Dr. N.S. Vaya, was mentally very active. He would read continuously. And that also kept, he said, Harish, when I read at 8 o'clock in the morning for 2 hours, I feel my brain is active. When my brain is active, I feel a lot of meaning in life. My mother is 86 as of now, mentally active. She reads, she discusses, and she moves. That also really helps people to be active. And number 4 is yoga or vipassana, whatever forms of meditation. It could be Shambhavi Mahamudra, it could be Sudarshan Kriya, it could be Tasbih, it could be anything. Also helps moods to improve. Maintaining the physical parameters and seeing to it that they are in touch with the doctor for the physical cases and they kept well. Feeling wanted, when the elderly feel wanted to feel better, finding life is also extremely important. And lastly, seeing that humor is a part of their lives and they're in touch with their peers or their younger ones, is active. Interaction with nature, yoga, exercise, nature, and cognitive activities keep anybody healthy, and this is important for elderly. They need to keep in touch with the doctors, but their blood pressure, sugar, and other physical parameters are well maintained. If they've had cancer, they need to meet the cancer doctor so that their parameters are well maintained. Playing with the small children and grandchildren also is very useful. Financial independence is also an antidepressant, by the way. I tell all elderly people not to give all the keys to the kids before they pass away. One master key, that they have enough money to take care of themselves, is very important. They depend on the children for the daily towel, dal, roti, and even for expenditure. It's really an anxiety-provoking situation. It works on their existential beliefs and they can get depressed. So money for themselves and not giving everything when they're alive, the children, is also a very important activity by which they can really maintain their health till they go. But in spite of that, if things happen, इसका कोई नहीं है, इसका psychologist होता है, इसका कोई नहीं है, इसका psychiatrist होता है. And lastly, my dear friend, what is very, very important is, just like Amitabh Bachchan says, दो बूंद जिंदगी की, as far as polio is concerned, एक गोली उदासीनता, please take it and you feel much better. Thank you.
Thank you so much, sir. I think there was one other question which I think you've answered from this. Apart from talking to a suicidal geriatric person and encouraging him or her to go for counseling, what else can we do? And I think you've given us all the tips that we can work with the geriatric population, especially our grandparents. And I think what sir said, that we can take a small step to make the society better with our own paternal and maternal grandparents, and I think we would have done our bit. And I think that's a very good input. Even we are aging, that don't give all the pieces to our children and they throw us out. Keep some for us till we go up. Law hai, will hai, upar jane ke baad they can take what we have made for them, but till we live, I think money, and we have the right on that money to enjoy it till we live. So thank you, Dr. Shetty. Thank you so much for taking time out and sharing. We really appreciate. We have so many students who were so eager to listen to you, and you've always been a pleasure to have. Over to you, Takreem. Thank you very much, sir.
Thank you so much, Dr. Shetty, for your valuable insight. We are extremely grateful that you take time to speak to us on suicide in geriatric population, informing us how important it is to be compassionate and empathetic towards elders and helping us identify the major signs of suicide. As aspiring psychologists, we truly agree that addressing this hesitance in mental health advisors and the medical community to help and acknowledge the geriatric population and ensuring their needs are met adequately is the need of the hour. As always, it has been a pleasure to have you here with us today. Thank you so much, sir.
Thank you, Takreem, Meghna, and the principal of the Nanavati College and the principal of National College. Thank you. Thank you, bye.
Thank you, sir.
Our next speaker is going to talk about marital conflicts. Even in the 21st century, marital conflicts remain an issue of incredible concern throughout the country. The effects of such conflicts can often be devastating. Marriage across cultures has often been denoted as a protective factor against all the storms and stresses of life, a cushion of love and care. So, why is it instead becoming an aggravating factor in Indian society? What still causes this abysmal results? To elaborate on the state of women who die by suicide through burn injuries and other means, we have with us Dr. Utkarsh Nayak Desai. He is a gold medalist in pharmacology and works in Victor Hospital, Margao, as an RMO in casualty and ER. His extensive work in the burn ward has often given him a chance to help patients who are women affected by burn wounds resulting from domestic and marital conflicts. He has vast experience in the domain of plastic surgery and burns and is highly skilled in burn patient management. With immense love for humanity and compassion for all, Dr. Nayak is here to give us a pragmatic insight on the deterioration of community mental health and give his perspective on dealing with burn victims, especially women who attempt suicide due to marital conflicts. We are glad to have you here with us today, sir. Over to you.
Am I audible?
Yes, sir.
Good afternoon. Thank you for giving me this opportunity to present today on World Suicide Prevention Day. My topic for today is burns, and I'll be speaking about key facts which are related to burns, as well as how we can prevent burn injuries. So let us see some global figures and the burden of disease. So over the world, around 1.8 lakh deaths occur every year due to burns. And the latest figures are from the year 2018, which are given by WHO. And the vast majority of them occur in mainly low and middle income countries. We will see as to why. In India, around 10 lakh people are moderately or severely burnt every year, which require hospital care. So it is not as if that there is a low incidence of this disease. So what is a burn? Activity, electricity, friction, and contact with chemicals. In our clinical practice, we used to mainly get thermal burns, which used to occur either by hot liquids, that is called as scald burns, either by hot solids, that is called as contact burns, or mainly by flames, which are called as flame burns. Now, who are at risk of these burns? So mainly these are females who are either cooking or either at home, and they are practicing unsafe cook stoves. Okay, so this higher risk is also because of open flames which are used for heating and lighting, such as diya. Also, self-directed or interpersonal violence are also factors, but they are very much understudied in India. Later on in the presentation, I will be talking about two case studies, which were either because of suicide by burns or either because of interpersonal or intermarital conflicts. Also, as compared to females, children are also particularly vulnerable to burns. This is because majorly this is because of improper adult supervision. In our clinical practice, we used to mostly get females who were either cooking or practicing the ritual of puja. There was this patient who was doing puja at home, and she did not come to know that her maxi caught fire. As a result, around 30 to 40% of her skin got burned, and then she was admitted in our burns unit. Also, there was one more female who was admitted because of was admitted because of the gas cylinder explosion. So this gas cylinder explosion, what she was doing was she was cooking, and she kept the gas cylinder on. So this gas cylinder, afterwards, she lit the match. As a result, it caught fire. What are the other risk factors for burns? So occupations that are at increased exposure to fire, such as firemen, also poverty, overcrowding, and lack of proper safety measures. Underlying medical conditions also play a major role, including epilepsy, peripheral neuropathy, physical and cognitive disabilities. How does epilepsy play a role in burns? This is because patient who get seizure, they also lose consciousness. As a result, if they are close to a source of fire or close to a source of burn, they can get severe to moderate burns. Also, peripheral neuropathy is a condition where the lower limb nerves are usually damaged, that is, the leg nerves are damaged. As a result, if a person is in contact with the source of burn, he or she will not come to know. Also, alcohol abuse and smoking are risk factors. Use of kerosene is a very common source of burns. This is because in lower households or in people from lower socioeconomic strata, they do not have the facilities for gas cylinders or even electric cook stoves. As a result, whenever there is kerosene leakage or whenever whenever these kerosene stoves explode, it will lead to major burns. Also, firecracker burns are very much common in India because of usually festivals such as Ganesh Chaturthi, Diwali, or any other festivals which are present in India. So, if a person is getting burned, what do we do? Is there a role of first aid, and why is first aid so crucial in burn? So, we will see regarding some do's and don'ts. So, what to do when a person is getting burned? So, suppose you are at how in your home or you're walking around somewhere. Suppose you see a person is getting burned. So, first mainly is to do. So, the first thing you are supposed to do is to stop the burning process. Before that, you cannot do anything. So, first of all, we are supposed to stop the burning process by removing the clothing which has caught fire. After that, you are supposed to extinguish the flames by allowing the patient to roll over the ground or by applying a blanket or by using water. Mostly sometimes we see chemical burns. See chemicals, suppose such as sometimes there is acid attack, so sometimes there is alkali attack. So in these patients, you are supposed to irrigate these burns with large volumes of water. Otherwise, the person will keep on getting deeper burns. Also, use of running water to reduce the temperature of the burn is advised because there is nothing else which you can do to stop the burning. As a result, running water or or tap water is used to reduce the temperature of the burn. After you have stopped the burning, you are supposed to wrap the patient in a clean cloth or a sheet and transport him to the nearest health center or the medical unit for further management. What all you are not supposed to do? Mainly, we used to get patients, used to come to the hospital while they were trying to save the patient from getting burned. They were also getting burned in the tube process. So, first of all, you are not supposed to start the first aid without ensuring your own safety. Suppose there is a person who is getting electric burns. So, you are supposed to switch off the electrical current first or the electrical appliance first rather than going and catching the patient on your own. Also, you are supposed to wear gloves for chemical burns. This point I cannot stress much upon is that you are not supposed to apply paste, oil, haldi, or raw cotton to the burn. Mostly people who used to come from rural areas, they used to do was that they used to apply toothpaste over the burn because it used to give them a cold sensation. But you are not supposed to do that because whenever in case of burns, what used to happen is whenever you're cleaning the wound, you cannot clean it completely because the person is getting severe amount of pain. So if you're applying toothpaste, it makes our life even more difficult. Also, you're not supposed to apply ice to it because it will deepen the injury. And avoiding prolonged cooling with water is also not advised because it will lead to hypothermia. Hypothermia being decrease in the body temperature. Now, a person has come to the burns unit. How are we managing these burns in our burns unit? So first of all, we have to assess the patient. We have to see whether the patient is all right or whether the patient is okay, talking, conscious, whether he's oriented, whether he knows whether he's in the hospital or not. So we have to assess all that. So essential management points include, first of all, we have stopped the burn. After that, we will do something called as ABCDE of burn. That is called as airway, breathing, circulation, visibility, and exposure. So in the airway, we have to see whether the person's airway is patterned from the mouth to the trachea. After that, we have to see in B, that is breathing, we have to see whether the patient is breathing normally or not. C is circulation, where we have to give them adequate fluids. D is we will see for any disability or any other injury which has been caused to the patient. And E is exposure. Exposure is very important because we have to know the amount of burns which has happened to the patient. So after exposing the patient, we will determine the percentage area of burn. The percentage area of burn is very, very important because other than that, we cannot manage the patient correctly, as mainstay of burns treatment is fluids. So in order to give this fluids, we have to give good IV, we have to get a good IV access, and we have to give early fluid replacement. Other than that, we have to also assess the severity of burn, which is mainly dependent upon the percentage of body surface area involved, as well as the depth of burns, which can be the first degree burns, the second degree, and the third degree burns, which you can see from the image. Now, a person has come. How do we decide whether the hospitalization is needed or not? So, a person who is an adult, if more than 15% of area is burned, we will admit him. If it is a child, more than 10% of body surface area, if it is burned, we will admit the child. Also, if there is any full thickness burn, in case of the very young or the elderly, in case of burns of special regions, such as in case of face involvement, hands, feet, or the perineum, circumferential burns, inhalational injury, or any other conditions which were pre-existing, such as diabetes, hypertension, or epilepsy. Now, what is this perineum? Perineum burns are usually perineum is the region of the body where your external genital organ or your buttocks are present. So, if we do not admit such patient, it will lead to contamination of the burn wound. So, as a result, we have to admit these patients also. Now, how do we treat? The treating of these patients is basically, first of all, after we have to see whether first aid is being done or not before coming to the hospital. If the first aid is not done, we will again do the same thing. That is, we will drench the burn under the tap water and remove all burn clothing. After that, we will start initial treatment. That is, we have to give them antibiotic. We have to give them a tetanus prophylaxis, and we have to clean the burn wound and do a sterile dressing with antimicrobial ointment, paraffin gauze. This is how a paraffin gauze looks. After that, we have to start the patient with injectable antibiotics, analgesics, and IV fluids. So antibiotics will mainly take care of infection, and analgesics is the one which is mainly taking care of the pain, because these burn patients are in severe pain. And IV fluids are very, very important also, because that is what is the mainstay of burns treatment. After that, for daily treatment, we will change the dressing daily. Also, we will assess the burn wound, and we will see for signs of infection such as fever and swelling. If the hands and feet are involved, suppose if the burn is involving extensive regions such as hands, feet, your chest, your abdomen, so the patient will be mostly in the supine position, or maybe he will be lying in bed. So as a result, because of long-standing lying in bed, the hands and the feet can develop swelling. As a result, their healing will get delayed. So therefore, we have to keep them elevated. And the main role of daily treatment is supplementation of adequate nutrition. So adequate nutrition does play a major role in the outcome of this burns patients. How is that possible? It is because the patient's energy and protein requirements will be very high because of catabolism of trauma, heat, infection, and demands of tissue regeneration. But we have seen in clinical practices that patients do not want to eat on their own. And obviously, it is because the patients 50 to 60%, 40%, 30%, even a small burn will pain a lot. So as a result, they have decreased appetite. So when patients are not eating, the only option is to put a nasogastric tube and give them feeds directly. So a nasogastric tube is when you put something called as a Ryle's tube through your nose and directly into your stomach and give them feeds. Mostly liquid feeds are given through this nasogastric tube. So the main role of this nutrition is because if you're not giving them adequate nutrition, if you're not giving them high protein diet, if you're not giving them high calorie diet, it will lead to anemia, it will lead to malnutrition, which is very, very detrimental. And it can lead to prevention of burn wound healing, result in failure of skin grafts, and prolongs the hospital stay. Now, how do these burn wounds heal? This burn wounds heal. The burn wound heals mainly by secondary intention, but superficial burns heal rapidly and either cause minimal or no scarring. The deeper burns, they will heal by secondary intention. This secondary intention is a way of healing where the skin from both sides migrates medially and joins and thus heals by scarring. And it can lead to hypertrophic scarring as well as keloids. So in order to prevent this hypertrophic scarring and keloids, in order to prevent further damage or further psychological trauma to the patient, we will prefer skin grafting. Does not mean that skin grafting will not cause scarring, but it will cause less scarring as compared to healing by secondary intention. This is the way how skin grafting is done. We have to take the patient's healthy skin And after that, we make tiny holes into the skin so as to increase the surface area. So this is how the skin graft looks after it has been placed over the raw area, and this is how it looks after it has healed. In case of children, we commonly see contractures. See, as I said, the burn wounds heal by scarring. So this in image A, we can see that the child is not able to open his hand completely. One at the index finger, one at the little finger. So these are the contractures. This is the hypertrophic scarring which is present. So when the child is growing, what will happen is that he will not be able to open his hands completely. As a result, it can interfere with the growth of the child. So we have to do surgical release in these patients. So this is the image B shows surgical release that is called as Z-plasty. So, and C is after which the wound has completely healed after the Z-plasty. Now we can see burn scars over the face. So it can cause severe life-changing cosmetic deformity. This is what is a facial burn which has happened, and as you can see, there is severe scarring. He's not able to even close his eyes, and there is scarring present all over the face. And this was a kid who had got burns over the neck, and this has healed by contracture formation. So he is not able to close his mouth. So in these children, we do surgical release so that the cosmetic deformity is corrected, but the scarring will still remain. Now we will see two case studies where the mainly in case of females who try to commit suicide by burning themselves. This is called as self-immolation. So the first case study is of a patient X. She was a 36-year-old female who came to our casualty with alleged history of suicidal burns after pouring petrol over her, and she set herself on fire at home following a fight with her husband. So there was some interpersonal or domestic conflict which was happening at home, following which she put petrol over her and set herself on fire. There was no previous comorbidities or psychiatric illness that the patient or the relatives gave us any history of. The patient was admitted, assessed as 16 to 18% intermediate to deep burns over the chest, upper limbs, and lower limbs. After that, we did the dressing. We started her on antibiotics, analgesics. And the main thing about any burns case is that they are all medical legal cases. So we have to inform the police. So the police were informed, and the reference was sent for psychiatric evaluation as to know why this patient attempted suicide by burn, and it was sent on an urgent basis. After that, the psychiatrist saw the patient. Psychiatrist opined that the patient was clinically depressed, and the patient was started on something called as sertraline, which is an antidepressant. After that, the psychiatrist advised us for strict observation so as to avoid any further incidents in the hospital. So the patient stayed in the hospital for about 15 days and then went home against medical advice as she had a young child to take care of. So here was one patient who tried to commit suicide by burning. There was some interpersonal conflict, and she was not giving proper history as to why she did it or what was the fight which was happening. But she did it, and we did her psychiatric evaluation on and on. So the main thing about this case history was that the husband does not visit the wife anytime during the stay in the hospital. Even when the patient used to come for follow-up, she used to cry all the time. She used to say that the husband, there is always a conflict at home. And she used to say that the husband was not giving her money for travel or even for any medications. So what we used to do, we used to give her supply from the government supply directly so that we could help her in some way, as she was completely dependent on her husband. For travel also, she used to spend around 800 or 1000 rupees every time she used to come to the hospital, because she used to stay around 20-30 kilometers from the hospital. She was from a rural background, so she was going through a lot of hardships. After that, during more follow-ups, most of her wounds had healed, but one over her left shoulder was not healing, and she was advised skin grafting. But still, the patient refused for a period of 1 month, as she was saying there was nobody to stay with her in the hospital, and she has to take care of her child at home. Eventually, during further follow-ups, she agreed to do the surgery, thankfully, and was discharged after 5 to 6 days of surgery. Then there was this case study 2. Case study 2 was the patient Y, who was a 24-year female and was referred to the burns unit with alleged history of suicidal burns, where the patient set herself on fire after pouring kerosene over her. This patient was married, had a history of psychiatric disorder, which the husband was aware before marriage. And the patient had sustained 24 to 26% intermediate to deep burns over the neck, over the chest, both upper limbs, lower limbs, with involvement of the face. Her mouth, her nose, her ears, all were involved. The patient was admitted and treatment was started. Also, the police were informed. So, what we did was that we tried to find out why she did it. So initially, when in the first 2 days, the patients don't say why as to why they did it, as to what was the reason behind it. So eventually, we tried to find out as to what was the reason as she had to commit this, as she had to burn herself. So after the police were informed, psychiatric evaluation was done and patient was started on antipsychotics, antidepressant, and sedative psychiatrist. Also, in the first 2 days, the patient was not ready to eat on her own, so a nasogastric tube was passed and the feeds were started on the next day. During her regular dressings, what we used to do was we have to do regular dressings to these patients. But during her regular dressings, Y was very cooperative, and she had an unnatural threshold of pain. Whenever we used to even clean very gently or even very thoroughly, she used to never complain of pain. When asked why she did it, eventually she said that she didn't want to live and she didn't have any purpose in life. She also mentioned that her husband has always been supportive and has taken good care of her in the past. After about 15 days in the burns ward, her wound started healing slowly. So the patient was progressing, but it usually takes time for the burns wounds to heal. So regular psychiatric follow-ups were also done as the patient had fluctuating moods and was having insomnia, for which the dose of sedatives was raised. So whenever we used to go to her, we used to ask her, "Are you okay? Are you feeling any pain?" She used to say something else only. She was not, she was answering the question, but she was also adding 3 4 points of her own, which were not relevant to the question. After that, eventually, she was offered skin grafting for her wounds, but both the husband and the wife refused and wanted to continue daily dressings. 70% of her wounds healed by day 30 of admission, and she was discharged and advised to continue daily dressings at a nearby health center and adhere to her psychiatric meds. She was given rigorous physiotherapy, mainly on the flexor aspect of the neck, to avoid these contractures as I had shown you before. Now, how do we prevent such incidents? We have to know that 90% of the burns are preventable. How do we do this? We have to improve the awareness. We have to develop and enforce effective policies so that people are not caught in areas. Describe the burden and identify the risk factors which can lead to burns. We can also provide burn prevention programs and strengthen the burn care. In addition, there are a number of specific recommendations for health, individuals, communities, and public health officials to reduce the burn risk. What we can do is that we can promote safer roof stoves and less hazardous fuels and educate regarding the loose clothing, apply safety regulations to housing designs and materials, and encourage home inspections. Also, lower the temperature in hot water taps and promote fire safety education also at workplace. And we can avoid smoking in bed also, which are also incidences which can lead to burns. Also, we can do is that we can use fire retardant fabrics for children's sleepwear, improve treatment of medical conditions which can lead to burns such as epilepsy, particularly in developing countries. Also, we can encourage further development of burn care system, including training of healthcare providers in the appropriate triage and management of people with burns. In my state of Goa, there is only one burn center which is present, and there is, it is the only burn center which is recognized, and it is the only burn center which is giving proper burn care to these patients. So we have to, increase the facilities, we have to give more infrastructure so that these burn patients can get treatment nearby them. Also, we can support the development and distribution of fire retardant aprons to be used while cooking around an open flame or a kerosene stove. There is a national program which caters to this burn patient specifically. This is because burns injury is accompanied by trauma, scars, and disfigurement, which takes years to heal, both physically and psychologically. So, this national program is the National Program for Prevention, Management, and Rehabilitation of Burn Injuries, and which is an initiative by the Government of India to strengthen the preventive, curative, and rehabilitative service of burns patients. Thank you.
Thank you so much, sir. Thank you for your valuable inputs on this topic, sir. This is something which is a very untapped area. We generally don't hear of burn victims. We hear of other means of suicide. So there are some questions in the chat box that I would like to, read out to you. One is, what is the quick home treatment one can use in emergency before taking the person to the hospital?
As I said, the only thing you can do is mainly first aid. If it is a very small burn area, like 1% or 2%, what we can do is there is a cream which comes that is called as Neosporin, or there is a mainly it is antimicrobial ointment which you can apply for 1 or 2% of burn. More than that, if it is there, there is a chance of getting infection. So home remedies is usually putting water over the burn and then cleaning it with a clean cloth and then putting this antimicrobial treatment.
Thank you, sir. So there's another question. How do medical workers in the burn ward cope up with the grief and deaths of burn patients on a regular basis?
Okay, there was a duty of mine where, 6 to 7 patients were admitted, out of which 3 patients died on that night duty. One patient died at 9:30, then the other one at 10 o'clock, then the last one at around 1 o'clock in the night. They were all really critical patients with either 30%, 40% with other comorbidities such as diabetes, hypertension, or epilepsy. There were other comorbidities which were also present. So coping up is very difficult because, as I said, it is 3 deaths in a night or 1 death in at least 2 to 3 days. Because these patients, are more than 30%, more than 40% of burns is very difficult to treat because half of your body is burned, and doing dressings is all fine, but after your skin is exposed like that, it will lead to infections. So coping up is very difficult, and there are the nursing staff, like we are doctors, we treat the patient, that is fine, but there are nurses, there is supporting staff who are not trained to cope up with such things. So there should be a way as to how they can view their grievances, or how they can how they can tell about their views about the conditions they are going through with.
Sure, sir. So for the last question is, when there is a medical patient and this patient is showing symptoms of burn and is a burn victim, the worst is already done. But how do we work on making these victims more socially accepted?
See, a burns patient, if it is involving the face, it is involving some major part of the body, such as the chest, the neck, which is cosmetically visible. What we can do is, we cannot get rid of the scar completely. We cannot, you can only give them functional improvement, but the scarring is always going to remain. But we can give them physical therapy, we can give them psychological therapy as to, for them to be better accepted, for them to better accept themselves as to how they look or what is their functional deficit. So that is the only way which we can do that.
Thank you once again, Dr. Utkarsh, on behalf of Department of Psychology, RD National College, and Department of Psychology, Maniben Nanavati Women's College. Thank you for taking time out and sharing your knowledge, experience. This is some topic which is very close to my heart because I have lost a very close relative, and this was out of a burn, she was a burn victim, but unfortunately, I think she only survived 15-20 minutes post the burn. And this has been many years, but I really wanted to understand this. So thank you so much once again for taking time out and sharing your views with us. Over to you, Takreem.
Thank you so much, Dr. Desai, for enlightening us with your knowledge regarding the seriousness of some of these unfortunate and unavoidable events. We all have read about victims who fall prey to this quite often, but to gain insight about the same from a professional perspective was truly eye-opening. The sad truth is that this could happen to any of us. But now, after the knowledge imparted by you, I am confident that we will be able to take care of ourselves and especially our loved ones better. Hearing about these case studies was absolutely devastating, and we can't even comprehend the amount of determination and hard work you put in daily to help them. With your expertise and in depth knowledge on this topic, we can only hope to perform such a noble job as you. Once again, I would like to thank you for taking time out from your busy schedule and gracing us with your presence. Thank you so much.
Thank you.
I now invite Dr. Gargi Kulkarni, a student of Maniben Nanavati Women's College, to introduce our next speaker.
Thank you, Takreem. Please welcome Mr. Vikram Kirtikar, one of the eminent personalities present with us today. Mr. Vikram Kirtikar acquired his master's in clinical psychology from RD and SH National College and SWA Science College in 2014. Post-masters, he has undergone training in rational emotive behavior therapy, REBT, from In Vivo Institute of REBT. Mr. Vikram's interests lie on a huge spectrum, some of them being working with patients who have anxiety, depression, personality disorder, schizophrenia, and adult Asperger's syndrome. He is currently working at Empower the Foundation as a senior psychologist and outreach associate. Empower Foundation is providing help and education to the children and the youth on their journey of emotional and mental well-being. Today, Mr. Vikram is present here to speak and spread awareness on the hashtag Recognize the Feeling. This hashtag connotes the need to understand and acknowledge feelings of our own and those around us, whether it be various psychological aspects of anxiety, suicidal tendencies, and so forth. We will now hand it over to him to take the lead and elaborate on such an essential topic. We're glad to have you here, sir.
Hello, good afternoon, everyone. I just wanted to know if I can, change the view so that I can see multiple windows. Is there a way to do that? Because I just want to see everyone's faces here, Okay, yeah, I think I've got the hang of it. Yeah, okay. So, good afternoon, everyone. Firstly, thank you for inviting me for this event. Thank you, Meghna ma'am. I don't know if you all are aware, I am a student of Meghna ma'am. So I'm glad to be here. Okay. So firstly, I would like to ask all of here, everyone, if you all are able to switch on your videos or answer through audio or even through the chat box, that would be really great. I would like to firstly ask everyone, how are you all today? How are you all doing today? Anyone? How is everyone today?
Thank you so much, sir. Feeling good. A little tired, but happy to see you here.
Okay, great. I'm getting responses in the chat box. Okay. All right, great. My next question is to the people who organized this event. I'm sure you all must have been working day and night, to get this event happening. How are you guys doing?
Perfect. We have kind of muted everyone, so I think you'll have to really refer to the chat box.
Yeah, that's fine. That's fine. Ma'am is always doing really great. But the students, I would like to ask you all, how are you all today? Chat boxes are also fine. Chat box responses. Okay. All right. Great. Good. Doing good, sir. Excited. Great. Good to hear that. Okay. All right. You all can continue, giving the responses in the chat boxes. I will be reading them as I go along. Okay. So I'm glad that all of you all are doing well. Okay. And just know that, there is a listening ear over here. Okay. Someone or the other around you who will listen to you. You just need to find that person, and it's also a good practice which I follow, that is to just ask how one is doing. That it's a very simple, casual, everyday question, but it makes a big difference. You never know what someone may be going through, and that one question can just help them share something. Okay. From that, so coming to today's topic. So we are World Suicide Prevention Day is tomorrow, and we're talking about suicide. Yeah. My specific section, hashtag recognizing the feeling. Okay, so firstly, let's quickly try and understand, suicide. Okay, so what is suicide? Suicide, in simple terms, is an attempt to end one's own life. Yeah. Okay. um, how does suicide occur? Okay. um, there are mainly two spaces which are observed. Okay, one is in a very impulsive thought process, which is a very spur of the moment thought process, and the other may be a form of hopelessness in the person, a long standing hopelessness. Okay. These are observed in some mental disorders. Okay, these particular kind of thought process, themes of thought processes. Okay, however, we're not going to be specific here today, talking about mental disorders. Okay, but we are just going to understand, where all these themes can come up. Okay. I'm going to be specific to the age group of adolescents and teenagers over here. Okay, so let's look at what we have over here. Okay. um, yes, of course. Illness. Okay. Mental illness. Okay, we have heard about depression. Okay. We have heard about emotionally unstable personality disorder. As per ICD and as per DSM, it's known as borderline personality disorder, right? um, there are other mental illnesses also, in which suicide can occur. Okay. In depression specifically, the hopelessness, helplessness theme seems to come up very prominently. And the impulsivity aspect is seen more in personality disorders, especially the emotionally unstable personality disorder aspect. Okay. Again, the presentation of an illness when it comes to a particular age group of adolescents to teenagers is slightly different. um, Personality disorders, because there are reasons why we would not really look into a personality disorder when it comes to this age group. I will come to the reasons. Okay. But if we had to look at depression. Okay. One of the biggest differences that we will see when it comes to adolescents and teenagers as compared to adults is the irritability factor. Okay. uh, uh, Low mood is expressed through irritation, agitation. Hmm? So that's one of the big differences. Okay. Now let's try to understand what's happening in this age. Okay, with the person. Biological changes. Okay, entire body system is getting reconfigured for the adult life. Hormonal changes. Hmm? um, uh, People are getting facial hair, their body is developing. um, Menstruation begins. Hmm? People understand that they're sexually active right now. A lot of changes physiologically. Okay. Then we look at identity formation. If you all remember, if we go back to the basics, Eric Erickson has spoken about a stage. Don't worry, I googled it. Okay, I don't remember it at the top of my head. Okay, but the stage is identity versus role confusion. Right. This is a very big stage in adolescent teenagers. खोज रहे हैं अपने आप को. Okay. Explicitly they don't say it, but if you would have observed the behavior not only in yourself but others around you, you would notice that wanting to be a part of the group, wanting to be a part of the cool gang, wanting to do the cool hip in thing, wanting to follow trends, Instagram reels banane hain, want to explore options. So many areas. Okay, so now here the identity is forming, the personality is forming. And that's where, when I said earlier that personality disorders is something that we really are a little cautious about in this, because the personality is forming, it hasn't yet completely formed. Okay, so but yes, we would know or understand, aage jaake, is it going towards, a personality disorder? And then there are certain things that can be done, in therapy to help the particular individual. Okay. um Parenting. Okay, now I this I understand that, we are talking about adolescence, but parenting plays a very important role over here. Okay. um Messages from the parents. Okay, one parent is lenient, one parent is strict, one parent is authoritarian, one parent is authoritative. Parenting styles, if you'll remember, hmm, okay, can cause a lot of confusion at this point of time. Okay. um okay, so these were just certain aspects that I wanted to highlight, because this is what the individual is grappling with in this age. Okay. Hmm. Now think about the part, when I said that irritability hota hai, and hopelessness, the person is feeling hopeless, or if there is a illness involved over there. Now just imagine all these things coming together and the person having to deal with all these things. I just pause and reflect. So many things. And on top of that, you have your studies, and you have your project submission, and you have your deadline, and so many things going on, right? Okay. Now, don't get me wrong, I'm not saying that these factors contribute to someone attempting suicide. Okay. But if we had to look at it the other way around, where the person is trying to deal with these changes all around them. Okay. And then somewhere, they are not able to deal with these changes, or the distress that they're experiencing, or they are thinking about these changes, in a very different way, and there's very much a possibility that, under the pressure or under the stress, the person may get these thoughts, or may plan or may think of, attempting suicide. Okay. When I started off, the session today, I asked you all the question, how are you all feeling? If you are able to just reflect on how important that question is. hmm, uh, there's a lot going. That question can help the person just, get some kind of understanding of what all is going on. Okay. Right. Now, when it comes specific to suicide, there are a certain things that, I would want to point out over here as a therapist. Firstly, let me make this very clear. There's nothing wrong in getting these thoughts of suicide. कुछ भी गलती नहीं है. Okay. But I will say it's not wrong, but it is concerning. Concerning why? Because we care about you. You are important and you matter. Hmm? You being here in itself is a big contribution. Okay. uh, when I have spoken to, many adolescents also, and adults also for that matter, and this one statement comes up, if I'm not there, it won't make a difference. People will cry for some days and then just forget. No, it does make a difference. You are important. Hmm? Okay. Everyone, please remember that it's not wrong to get these thoughts of suicide, but yes, it is a concern for your well-being, and that is why it is better if it is addressed. Okay. um, Another very important aspect, guys, um, if anyone even mentions casually, uh, anything connected to, ending life, suicide. um, I'll tell you, statements like abhi sab theek ho jayega, now everything will be fine, there'll be no more problems in my life. Or maybe, behavior of suddenly wanting to, or seeing this pattern of behavior, where they're meeting people, wanting to meet them, they haven't met, and they just, it's like, they're going and meeting everyone, and it's like they're completing something. Okay, these are again just few sides. I'm not saying that har koi karega. There may be more that we may not even be able to identify, but these are few things that we can watch out for. Okay, so if someone even mentioned anything casually related to, suicide, ending life, please, 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 please do not ignore. Okay, and immediately, okay, get them help. Okay, it can be at your local hospital in the emergency, where there are professionals who are trained to take care of a person who is experiencing this state of mind. Okay, a mental health professional, psychiatrist, definitely. Okay, um, don't leave the person alone till the person has professional help of some kind. Okay, be around the person. You don't need to be controlling of the person. Just be around them and tell them that you're there for support. Okay, there are certain helplines which are 24 by 7, which are manned by psychologists. Okay, yes, they can contact those helplines and you know talk to someone. Okay, um from this, okay, so these two are very important things. Okay, one is, there's nothing wrong to get thoughts of suicide, and second thing, if someone even mentions it casually, please help them, please guide them to a professional. Okay, now coming to certain aspects which are specifically related to connecting to this age group in when it comes to therapy. Okay, so when they walk into an OPD setup. Okay, so number one is that parents bring along the child. Okay, um the adolescent or the teenager may feel somewhere that they are did something wrong that has happened, and they are being brought to someone who is going to now do something about it. Okay, like a therapist is viewed in an authority figure um, perspective. Okay, um, they may not be willing to talk. They may show reluctance, they may show resistance. Okay, these are certain challenges. um, Again, as I mentioned, thoughts of suicide. Okay, I will be answering. These are very interesting questions coming in the chat box. I will be answering. Okay. um, Thoughts of suicide are wrong, then uska repercussion क्या होगा? हम्म अगर किसी को पता चला तो what is going to be, how is it going to impact me? क्या बड़ा ऐसा होगा? So they may the person may refuse to say things. So again, I know I may sound repetitive, but let me make it very clear. It's not wrong in any way. Okay. um, Thirdly, this is the age of identity development. Okay, so there's a lot of curiosity about a lot of things, and the person may have indulged in an act of curiosity which they may consider wrong or taboo or bad. Okay, then the question about will I get caught if I say something? Will this reach my parents? Hmm? I remember seeing this on television. There is this one show which shows which has representations of real life crimes. Okay, and in one of the episodes, I saw that these four teenagers, they went to acquire some adult services. Okay, and then they were getting blackmailed by the person, and then the show goes on to show us that then they did not think of the only option that they could think of to get out of all of this was suicide, um, which is very unfortunate. Okay, if that was a thought process that came, because let me make it very clear that there is no problem, no, however severe it must be, there is no problem which cannot be dealt with while we are alive, and we can get help for it. There are professionals trained to facilitate this process. Okay, so I'm getting some noise. Is someone off mute? Yeah. Okay. So yeah. So there is always a way. There is always a way. We just have to find out the way. It may take some time, if depending on what the problem is, but there is always a way. Please remember this. Hmm? And just think about it logically. Okay. Um, of course, logically is a wrong word to use here, because in that state of mind, thinking logically is very difficult. Okay, but there is, so there is suicide, and then there is the beyond the suicide, and then there is this side of the suicide. Okay, beyond the suicide, no one knows kya hai. Okay, people use these statements कि सब end हो जाएगा, सब खत्म हो जाएगा, the pain will go, but no one really knows. Let's be very honest. Okay, I don't. Okay, huh? Um, on this side, yes, there is distress, there is that pain, hmm? But there is also things that we can do to gradually reduce that distress, whatever it is, however severe it is. And this side of suicide, that is life. Okay, there is there are research based processes, research based scientific processes out there to help you. It's just about you know doing it. And again, I'm not going to say reach out, and I'm not going to say tell someone. No, I understand how difficult it can be in that state of mind. Okay, but do try to connect with someone who's trusted. If not comfortable with someone known, do approach a professional. We are ethically bound to maintain a level of confidentiality, and we will understand. And even if there is some kind of communication that's supposed to happen between you and the parent, we will facilitate that process. You're not alone.
Hi, Vikram. Sorry,
Yes.
hi. Sorry to budge in, Vikram. This is Meghna, ma'am.
Yes, ma'am.
We are going a little spillover on time and the other speakers. Then we wanted you to take some questions from the students.
Yes,
So
ma'am.
if we can start that, please. There are a lot of questions coming in, uh, which I think are relevant to student suicide. And if that's all right, can I take the first question, please?
Yes, ma'am. Sure, sure.
Yeah. So there is a question asked here that what is the probability of a person who tried to commit suicide once would attempt to do it again if they don't get socially accepted?
Very high. Very high probability. If there is a history of suicide attempt, please be very concerned about this person, and please ensure that they get the right professional help.
Thank you, Vikram. There's another question from Sagarika. She
Mhm.
asks, what are your thoughts on educating high school students on suicide prevention? Like the way we have sex education, do you think suicide education and prevention should be discussed in high school?
Yes, certainly. In fact, I would go on to say that mental health and mental illness, is not spoken about. I, being a psychologist now, I remember my school days, and I wish there was a subject like psychology which was a part of my school curriculum. I would have been able to deal with a lot of aspects in a better way. But yes, definitely it could be a part of school program.
Thank you. There's another question. How can parents create a
Mhm.
safe environment where
Mhm.
children find it safe, easy to talk about their mental health, to discuss it with their parents
Yes,
before
very
they
nice.
attempt a suicide?
Very nice question. So number one is there is this misconception that if we talk about suicide, then the thoughts will be put in that person's mind and the person will attempt suicide. No, nothing like that happens. If that were the case, we all are sitting here, we are talking about suicide. I must have said it more than 10 times. We all would have, you know, by now, done something. There's nothing like that. It is a state of mind which can be created by an illness. So it is important to talk firstly, openly about suicide, hmm, about mental health, about mental illness. We see a lot of people talking about heart diseases, angiography or angioplasty hua. Like it's like, they have got a medal, you know, or they have done a PhD on that. But no one talks about mental health or health concerns or, suicide. So it's important to have that open dialogue. It's just like another illness, like how a physical illness is. As we talk about typhoid, malaria, and COVID, similarly, we can talk about depression, anxiety, and other mental illnesses.
Thank you, sir. There's another question from a student who asks, I feel there are some people have a trait of self-harm. How can they be taken out? I think what he
Yes.
wants to ask is, how do we work on this trait
Yeah,
of
yeah,
self-harm?
absolutely. That's a very nice question. So, I mentioned earlier emotionally unstable personality disorder. Okay. Uh, uh, it it is basically a disorder with the personality wherein, the people may use a coping strategy, self harm as a coping strategy. It's like, see, I'll give you a very simple example. When, let's say, our leg is hurting, okay, but then we, just pinch our finger and the pain happens over here. For that amount of time, the pain on the leg will reduce because this pain is more, okay. What is happening over there is they are experiencing emotional pain, okay, very extreme emotional pain. And when they are indulging in self harm, that's helping them reduce that emotional pain. Now, it's a coping strategy, but it's a maladaptive coping strategy. Hmm? There are ways to provide or, create adaptive coping strategies. There are certain therapies like DBT, that talk about that. And yes, definitely, they can get help.
Vikram, the questions are just pouring in and pouring in. I think this is, there's one last question I think we'll take from one student. Is there any way, and I think this is a very interesting question, is there any way to help someone who's under the age of 18, so basically a minor who engages in the act of self harm, and the parents feel that the child is too young to seek therapy?
Okay. First, the parents can go to the mental health professional, clear out all their doubts, okay. But I will say this, at whatever age, please approach a mental health professional. Do not delay. Hmm? It is very helpful.
Thank you so much, Vikram. I mean, you can see in the chat box that the questions are still pouring in. There's a lot of validation asked by students about what they have, how they have worked with their friends who have attempted suicide, etc. But because of short of time, I think we will not be able to take all the questions, but we will definitely forward the questions to you, sir,
Yes,
through a mail, and we can forward the responses back to the students on private mail. And I
absolutely.
think from the flow of questions, I can validate that you've really touched and done justice to your hashtag topic really well. This was a topic, I think it's very important. Even when we are in the profession, we keep hearing students, having thoughts of suicide, may not have gone and attempted, but I think it's kudos to those students who come up and talk. And I think that's the message you gave, that reach out. There are professionals,
Absolutely.
and there are helplines, and there are professional bodies, and we'll be hearing about them in the next couple of sessions, where you can reach out and there's always a solution. And I love that word. When you say impossible, it says I am possible. And I think
Yes,
that's what Vikram sir is resonating. A very positive person keeps telling me a lot of times that, ma'am, you should do this therapy, learn this, learn that. So thank you so much, Vikram sir,
Ma'am,
for
just one last thing that I just
sure,
wanted to
sure,
leave. I wanted
sure.
to leave on this note is that let's try and understand and guide rather than reprimand and shame. And
Lovely, lovely. I think that's a very, very nice saying. So, thank you on behalf of RG National College Department of Psychology. You've done kudos to our department and, of course, Department of Psychology, Manivan Nanavati Women's College, for on behalf of them for taking time out. I understand it's a weekday and how busy you are. Sir sees approximately 10 to 12 cases from morning to evening in person, and then there are so many other Zoom cases, but he very gladly agreed to come. So over to you, Gargi. Thank you, Vikram.
thank you, ma'am. Thank you, everyone.
I would like to take a minute to thank Sir. To quote Charlie Brown, a beloved character that has presented the importance of social support and mental health to all age groups over the decades, asking for help isn't weak. It's a great example of how to take care of yourself. Thank you, Mr. Vikram Kirtikar, for your enlightening thoughts on this very important topic. We appreciate having you elaborate on the ways signs of depression can manifest and present themselves in the adolescent age, a time in a person's life regarded as a turbulent and confusing age, especially with the added challenges in the modern era. You explained it in such an effortless way. You presented it in a way that everyone here could easily connect, understand, and empathize. You also mentioned how necessary and effective it is to reach out, to respond to disguised cries for help through social support and professional help. We thank you for emphasizing how important a person's life is, that their presence matters, and ways in which we can let them know the very same, which is undoubtedly of great importance. It was a great pleasure having you as a speaker here. Thank you, sir. Takreem will now be introducing our next speaker.
Thank you, Gargi. Our next speaker, Ms. Tanuja Babre, is a program coordinator at ICOL and is here to give us a multidimensional insight on how to break loose the loop. That is, how to break the loop of suicidal ideations and focus on crisis aversions by seeking better resources. ICOL, which is an abbreviation for Initiating Concern for All, is a pioneering and empowering mental health project which was started in 2012 by School of Human Ecology, Tata Institute of Social Sciences, and aims to provide a free professional counseling to people in need. Ms. Tanuja is an exceptional mental health professional with expertise in the domain of mental health, psychosocial well-being, community, and technology-assisted mental health services. She is a professional with a counseling psychology background, offering psychotherapy services and mental health supervision. Her work and passion for the community and social services are indeed commendable. Without further ado, I would like to invite Ms. Tanuja Babre to address our audience.
I hope I'm audible.
Yes, ma'am.
Thank you so much for the invite, first of all. I've put on a stopwatch, so I'm going to ensure that I don't overshoot the time. So that leaves us some time to look at questions as well. So when Dr. Meghna reached out to me and told me that if we can talk about your work and how is it that we can seek support and build resources, not only from a crisis intervention point of view, but even from a point where people experience distress. I started thinking about how do I link the two, and do I talk about ICOL and do I talk about our work, or do I talk about suicide prevention? And today, I don't want to leave all of you with a lot of numbers and statistics and figures, but I feel like I want to leave you all with a perspective to when we approach suicide prevention and the work in the area of broader mental health. So before I move ahead, allow me to take some time to talk about ICOL. ICOL is a national level technology assisted helpline service. We are a field action project of the Tata Institute of Social Sciences. So TISS is a teaching university, it's a social sciences university based in Mumbai with campuses across the country. And the faculty who works in TISS has a long-standing tradition of not only doing research and teaching, but also initiating various programs that respond to issues of violence, health, equity, social justice, and so on. These programs are known as Field Action Project And iCall is a project that was started with a vision of creating affordable mental health services, support, and also replicating mental health services to be able to bridge the mental health care gap, which we see in India today. Our flagship program is a national level helpline, which has been around since 2012. We run 6 days a week, 14 hours a day, and offer free professional psychosocial counseling services over telephone and email. In addition to that, iCall works closely to start special helplines, disaster response projects, and so on. We engage in research, primarily in the area of youth, adolescent mental health, suicide, technology, wellness are some of the key areas that we have gotten involved into recently. We also research our own model to know what are some of the methods or what are some of the feasible ways in which we can offer affordable mental health services. We engage in capacity building with public and private partner, and we engage in knowledge creation as well. So now that I have gotten over this part, let me talk a little bit about suicide and suicide prevention. So the theme for this year's World Suicide Prevention Day is creating hope through action. And it sort of makes sense to be able to have this theme after the year that we all have had. If we look at just the experience of COVID-19 itself, we all have experienced it in some way or the other. We all have probably experienced more or less similar things. We have experienced probably getting infected, the fear, worry about the future, uncertainty. We have experienced feeling hopeless. We have experienced not knowing what the next steps are. We have experienced frustration, maybe losses of jobs, hopes, dreams, loved ones, maybe gotten infected ourselves. However, these experiences may have been same for all of us, but the impact of these experiences have been very different on everybody. And that brings me to the point that all of us, depending on the kind of social location, on the kind of intersectional identities that we carry, will determine how does our mental health get impacted by these experiences, which are so-called equalizing, but the impact of it is not equal. So when we look at suicide or the issue of suicide in itself, it is also closely linked with vulnerability. It is also closely linked with marginalization. As we link this forward to mental health, there is research and enough data to prove that there is a positive association between hope, optimism, faith, positive mental health, and suicidal ideations. When we look at mental health challenges or distress, experiencing mental health challenges is an extremely, extremely isolating experience. People can feel that it's just me who is going through this. Due to the stigma which is there in our country, people may be really scared to talk about it, may be really scared to open up about it. But however, these sort of normal reactions to abnormal situations in our life, what Mr. Vikram was speaking about, I heard a little bit of his speech, and he was talking about it's okay, all of us can experience it, it's normal to experience it. So we are experiencing these normal feelings, but they're an outcome of abnormal life realities. And when we are responding to those life realities, or when we are even experiencing those abnormal reactions, it can push us further ahead to the margins. And it can push us further away from people that we love, people that we care about, services that we can access, support systems that we think can accept us or reject us. And all of the shaming, judgment, fears can lead to people being cut off from other resources. And that is where the issue of hopelessness and helplessness comes in, whereby people feel that they don't have any other resources to be able to address, and thus feeling suicidal or suicidal ideations may come in. Persons may even make an attempt, or sometimes, unfortunately, even complete an attempt. But when we look at the work that we are doing in terms of offering services and creating resources, what is it that we have to keep in mind? I think first of all, we need to know where do we even start from? Do we start from addressing mental health? Do we start from addressing suicide prevention? Do we start from creating awareness? Do we start from telling people that it's okay to not be okay? Or do we start from just
Has ma'am's screen frozen the screen?
Yes, ma'am.
Okay, we'll wait for some time.
Ma'am,
Hi,
please.
sorry, I think I got dropped out. Am I audible now?
Yes, ma'am.
Yes, yes. So sorry about that. Can I just give me a moment? I'm just anyways going to switch my network to avoid it. Hi, sorry. So I was talking about where do we start to respond to these mental health concerns? Do we start by spreading awareness? Do we start by telling ourselves that it's okay to seek help? Do we seek help ourselves, or do we encourage our friends, our family members, or do we set up services? Do we do suicide prevention? What is it that we do? So the first important work that we can do as an ally, and the support that we create for people, would be sort of creating a place which offers people hope. See, remember that hope is fundamental to be able to live a good life and to be able to live a fulfilling life. Yeah. What is it that we look forward to when we wake up? The kind of hopes and dreams that we carry, the kind of aspirations that we carry. So it's very crucial to allow us to continue living the life that we are living. When we approach resources, when we approach people with hope and to help create the hope in people's lives, we are offering people a reminder that there is an alternative to the distress, the pain that they're experiencing. We are not making false promises to people, but we are really trying to help them understand that together you and I can figure out something else. And no matter how long it takes, we'll work together to figure that out. If you look at the research of suicide prevention, mental health care work, about 40% of what is dependent on whether you will be able to, if you look at data from helplines which do suicide prevention, if the counselor has managed to create hope in that conversation, there are 40% chances that the counselor would have saved the client who's feeling suicidal. And that's how powerful the role of hope is. Yeah. So where do we start? The job is to really start on smaller steps, to build on smaller steps. Nothing is as big, nothing is, we are not hoping that change will come in today. Our problems were not created in one day, but our problems were created over perhaps many years, many months, and so on, right? So helping people understand that even one small step is important in working towards the problem. When we look at strengthening people's resources, always remember that even the fact that they chose to talk to you is a sign of resilience, is a sign of courage, and that itself should be appreciated. So people are not passive responders to their stories. People are active sort of action makers or change makers to their own stories. And it's really important to help people see that and help people understand that. And that action or the ability of their own ability to be able to bring that change in their life can be a very big contributor to them building this hope in their life. We have to locate the problem, and the problem is the problem which is outside of the person. The person is not the problem. In psychiatry, in psychology, we are taught symptoms. We are sort of taught depression, anxiety, schizophrenia, OCD, whatnot. But these are just symptoms, outcomes of what people feel when they are hopeless. These are not people's identities. People's identities are much richer than that. So therefore, there is no one-stop solution to suicide prevention or no one-stop resolution to feeling hopeless. But for us to be able to recognize these problems and challenges which are outside of individuals, and how we as mental health allies can support people in responding to these problems or these symptoms that have been created as an outcome of their life difficulties. Now, how do we do some of these things at iCall? Let me tell you a little bit about that, which I think are some of the best practices that we have been able to develop. So first of all, at iCall, we offer, the service that we offer is anonymous. The service that we offer, anybody from any part of the country can reach out, don't have to tell their name, don't have to talk about what is going on, don't have to give their address. They can just pick up the phone and speak to a professional. This anonymous service has been created to offer this anonymous service. If I can request the host to please turn off annotation. Thank you very much. Just a minute, I'm just going to do that. Sorry about that. So the aspiration is to be able to show people that we care. We offer empathy to people. No matter what space they are in, it's important for them to feel validated. By telling them that I get why you feel suicidal. Perhaps if I was in that condition, I would have felt that too. Is not you encouraging them to take that step, but to tell them that this normal reaction to your abnormal life situation is perfectly understandable. But also tell them genuinely that I'm here and I care about your safety. And no matter how long it takes, I'm here to support you through this in ways that I know how. And when I run out of resources to be able to help you, we'll reach out to more such people who can help us through this. So we offer referrals to people. Sometimes we offer referrals to legal aid services. Sometimes we offer referrals to debt counseling services. Sometimes we help people connect to their family members. But really help people understand that, oh, you've been feeling suicidal since 2 years. But then what happened? What made you not take a step for all this time? And people would tell us smallest of stories. They would tell us that I made a promise to my wife who passed away that I would never do this to myself. Or they would say that my mother used to say when I was small that people who end their lives like this are never happy, are never able to get satisfaction, God will never accept them. Even these smallest of things are very, very crucial in helping people create hope. So creating a safe place for people, an anonymous place for people where they're not judged is extremely important. Some of the things that I also want to then talk about is bringing it back to us. So what do we do again? Because the point is of creating hope through action, right? So when we're talking about creating hope through action, who is the catalyst in trying to create this hope? It's all of us. It's you, me, our friends, our relatives, our loved ones, our pets, and services that we are hoping to create, organizations that we are hoping to work with, the kind of care work that you may be aspiring to do in your future. Change and action can be created through all of those resources. But before going to that direction, it's also important to look after yourself. All of you are in a care profession, and after a point of time, it can be difficult to sustain that. People come to care workers not with happy story, but with very sad and very difficult stories. So it's important to first take care of yourself to be able to take care of others. You know, when you're flying in a flight, they tell you that first wear your oxygen mask before you put on somebody else's. So remember that as you may be going through your years of profession in the coming few years, or as you may be joining the profession in the coming few years. However, when we look at being responsible for action, it should be collective action. We all have a little bit of something to do. It could be perhaps asking somebody how they're doing. You know, if I ask you how you're doing, you will say, I'm fine. And it's such an autopilot response, right? But make it a point to ask people twice. No, but how are you really doing? Creating safe place for people to let them know that, hey, if you ever feel like talking, I'm here and you can reach out to me. Maybe sharing numbers of helplines, resources, community organizations to them for as and when they may need these resources. When you look at any sort of care work, taking care of yourself and imbibing that same value in other people is extremely important. So when we talk about suicide prevention, it's not just through helplines, it's not just through hospitals or emergency care units. We all can do a little bit of our work by maybe creating awareness, by maybe initiating a conversation with our friends, by maybe reaching out to somebody who you think is feeling low, by maybe putting up a poster or a post on your social media saying that, hey, if you ever feel like talking, always know that I'm here and I care. And those are some of the smallest of things that you can do to be able to create resources and to be able to create hope for people. Sorry. I have a small exercise for all of you that I brought in, and I thought it may be interesting for all of us to do this exercise. Just give me a second. What I've done is, if any of you have ever used a Mentimeter, I'm pasting a link in the chat. You can either click on the link or you can go to, I'm sorry about that. You can go to menti.com and enter this code. If you click on the link in the chat, you'll be taken to a website. And once you go to the website, you'll be prompted for a question. I'd like you to go to the website and just answer that question. In case you're not able to click the link on the website, then what you can do is go to menti.com and type in a code. And I'll just tell you what is the code is in a second. The code is 34096185. There is one simple question to type in and talk about what makes you feel hopeful. I've again pasted the link in the chat, or you can go to menti.com and type in the code 34096185. Okay, there are some responses which have started coming. People have said meditation makes them feel hopeful. Food and music makes them feel hopeful. Their family makes them feel hopeful. Animals. Seeing your mom's happy face. Your daughter, your thought of your husband, your family. Listening to music. Yeah. Beautiful aspect of life. I know life has its beautiful aspects, which I cannot miss at any cost. Opportunities that come to life, working, helping, keeping self busy, reading books, watching movies, seeing stories unfold that are there and is always more to do. Life goes on. Small joys. And new episode coming out. Yes. Dancing. Dancing like nobody's watching. Playing basketball, mixed martial arts, role models, music, friends. I feel good time will come soon. Hope about future. Small joys, doing yoga, hard work. Food, spending time with family, music, dance, long talks, traveling. Okay, thank you so much, you all. So this was just a small attempt to sort of remind us to slow down and to focus on some smaller things that we may have in our lives which make us feel hopeful. And as we're talking about all of these things, it's also then important to remember that when we work with clients, the same thing can happen. When we work with clients, we have to take small steps to be able to create hope. Before I end this talk, I just want to leave the conversation or my speech with a small quote from one of my favorite authors who does a lot of disability work. Their name is Leah Lakshmi. And Leah Lakshmi talks about, as individuals who do care work, we may make the mistake of approaching the idea that survivorhood is a thing to fix, it's a thing to cure, or it's a thing to get over. And that a cure is not only possible and easy, but it is the only desirable option. That itself is a foundational belief in mainstream ways of understanding survivorhood and survivors. The hope as care workers is not to help people move on, not to fix what is broken, not to help them get over it. But as a care worker, our job is to help people create a life which is worth living. With this, I'd like to just leave you with the number of our helpline, which is iCall. Thank you so much for inviting me. It's a free psychosocial counseling service run by professionals based out of TISS. If you or anybody you know is in distress, you can reach out to this helpline on telephone or email. We are a multilingual service, so you can reach out to us in any language. Thank you so much for having me here. That's all for me.
Thank you so much, ma'am. And absolutely professionally, the time was just bang on. I think your stopwatch was perfectly timed because we have a lot of questions for you. Ma'am, if you can take a few of them. There is a question for you, ma'am, how to break through from the sense of hopelessness that weighs much more than hope.
It's true. I mean, the sense of hopelessness does weigh much more than hope. And the thing about it is that if you look at negative experiences or difficulties, what happens is that every time we are in pain or every time we are experiencing some sort of challenge, the tendency is to recognize that, oh, this always happens. Oh, this always sort of goes on. We do a lot of workshops for corporate. I work a lot in the area of workplace mental health. And we always talk about how managers catch their employees, are used to catching their employees in the act of doing something wrong and not the act of doing something good. And sometimes I feel we do the same thing with our lives. We are used to catching ourselves in the act of doing something wrong, in the act of feeling bad, in the act of feeling pain. But we barely take time to recognize some of the things that we may be enjoying, some of our achievements, small milestones, things that are making us feel hopeful. And that's not so much of an individual mindset. Also remember that we live in a capitalist culture, which thrives on, which thrives on productivity, the whole hustle culture that you have to try, you have to push, you have to achieve big things. I mean, around you, everybody is becoming an influencer, somebody is doing something great, somebody is starting a startup. So the pressure is tremendous. However, little by little, somewhere that critical voice that tells you that you're not good enough, that is something that we should start addressing at some point of time. For some people, they are able to address it with tools and resources that they have built themselves. But for some people, it may involve seeking help or talking to a professional counselor. No matter what it takes, it's always really important to remember that the hopelessness that we are experiencing is from our perspective. If our loved ones were going through something like this, we would really want them to come to us and speak. So even for you, there are people in your life who really want you to come and speak and not go through the same thing all by yourself.
Thank you, ma'am. Tanuja, there's one more question.
Yes.
Have you ever encountered a case online where you were unable to help? If so, can you briefly discuss and explain what you felt at that time?
Yes, yes. I mean, absolutely, 100%. And honestly, if you ask any mental health professional or any care worker, their answer to it will be yes. If you look at the need for mental health services, if you look at the issue of suicide and self-harm, suicide is the leading cause of death in India amongst adolescents and young people. And globally, we rank number 2. So it's not any other illness, it's not any other issue, it's not some, life-threatening illness of cancer or TB or something like that. It's suicide, and that stat itself is so upsetting to hear. So the number of people who need resources and the number of people who need services is very, very high. And we always say that, one I call or a 10 I call will never be enough to be able to cater to mental health needs of other people. So yes, it has happened in times where we've not been able to help. Sometimes our partners will tell us that somebody has written a status and the only thing we can do is, hey, can you get them to call us? Otherwise, we don't have their consent to call them. Sometimes it could be clients that you may be working with who feel hopeless and say that, okay, maybe I don't want to access this service and I don't want to, maybe I want to do something else. So it does happen. But I think something really important as anybody who's offering therapy or services is to have supervision for themselves. To be able or to even have personal therapy for themselves. And that is how you'll be able to process it. That is how you'll be able to make the service better. So that the next time this happens, you're able to reduce the chances of somebody feeling hopeless or somebody going rejected through your service.
Thank you, Tanuja. We'll take the last question. It says that what was one of the most challenging things you faced when you had to counsel individuals on call instead of face-to-face counseling?
So if you look at technology-assisted services, the biggest challenge is that you can't see the person. And because you can't see the person, then that leads to sometimes missing out on a lot of missing out on their non-verbal skills and missing out on what is it that they are feeling. And sometimes you may have to go through a lot of clarifications to be able to ensure that you're on the same page with that person. However, what I also want to say that there are benefits of technology assisted services and there are also challenges of technology assisted services. The benefits include that people feel more safer. They don't have to tell their name. The shame, stigma that they may carry otherwise, they feel much more safer to reach out and talk about their mental health needs or resources. So there are challenges, but I have also found that telephonically, a lot of clients are more expressive. The kind of work that I would do in face-to-face over 3 sessions, I'm able to do that over 1 telephonic session. It's more accessible, more flexible. We can reach out to more people. So there are challenges that are associated, but there are also benefits that are also associated. It allows us to reach somebody who may be in the remotest village of Manipur, who may not have access to good, ethical, good quality services because they're based in metropolitan cities. So through iCall, we are hoping to make mental health a necessity, somebody that everybody can access and not a luxury.
I think that's a great initiative. Your last line itself is really, it has a lot of passion, and it shows that your involvement through iCall is great, and your reach out is, like you mentioned, in every language and every corner of the country. You are trying to, extend your services, especially the rural sector. And I think that answers the last question also, that with the technology being on our side during this 1.5 years of COVID, you have managed to reach out to a large number of people. A lot of students have asked for, how they can reach out with iCall, and I think ma'am has put down the helpline number. Tanuja, can I please request you to put it once more in the chat box?
So I put down the picture, but I'll also paste the number for you.
Right. So students, we have the number on the chat box. This is a request to everyone to please take down the number and keep it on your mobile, like the way we have our dentist number, we have our doctors. It's important to keep this number, and hopefully you'll never need it, but please extend it to anybody who needs it. Thank you so much, Tanuja, for taking time out once again from your busy schedule. Ma'am is extremely busy, extremely, like ma'am said, that it's a helpline that is working right from 10 to 8 in the evening. And being a coordinator, let me also tell you that documentation is done very, very well when it comes to these phone calls. It's not just, like a telephonic call center that you pick up and try to hurry up calls. There's a lot of involvement, and everyone who takes a call is highly qualified professional. And I can guarantee you this, that you will receive help. So thank you once again, Tanuja, on behalf of Department of Psychology, RD National College, and Department of Psychology, SNDT affiliated Maniben Nanavati Women's College. Over to you, Gargi. Thank you, ma'am. Over to you, Gargi. Over to you, Takreem. Yes. Okay.
We wholeheartedly thank Ms. Tanuja for being a part of this program and sharing her valuable time with us this afternoon. Your strive to extend a helping hand to everyone is extremely admirable and has inspired us to do the same. We have no doubt that your initiative is not only helping innumerable people, but also reassuring us at the same time that even when we feel like we have no one to go to, there is always people like you we can turn to and put our trust into. Highlighting that we need to take care of ourselves first before we reach out to others to help them is incredibly important, and we thank you for emphasizing on the same. The steps you've taken to eliminate the stigma associated with this domain of mental health is highly appreciated, and we are in absolute awe. We extend our gratitude towards you and your commendable service to the society. Thank you so much once again. Gargi will now be introducing the last segment of our webinar.
Thank you so much for having me here. Wishing all the best to all the students and good health to everyone.
Thank you, ma'am, and thank you so much, Takreem. Grim statistics have revealed suicide as the leading cause of death for women and girls ages 15 to 49, and the rate appears to be rising. To raise awareness about the suicide epidemic in India and provide suicide prevention education and resources to the public with a primary focus on the women of India, a revolutionary organization, Sisters Living Works, came into being in 2015. Germany Kent, a renowned actress, author, and speaker, once said, "Reach out and help others. If you have the power to make someone happy, do it. Be a vessel, be the change, be the difference, and be the inspiration." And these words echo in the work of those at Sisters Living Works. To inform us on the importance of spreading awareness about suicide and support and creating a hashtag open space for all, it is my absolute pleasure to introduce two eminent representatives of Sisters Living Works, Ms. Meenakshi Nagwekar, Director at Sisters Living Works, and Ms. Sachi Murki, Training Manager at Sisters Living Works, who have both graciously taken the time to speak with us. We're thankful to have you here with us today.
Thank you so much. So almost good evening everyone. And it was with great pleasure. I mean, we are here, I and Sachi, both of us. So without wasting much time, I think the session has already got delayed much. So we'll talk about what the work we have been doing at Sisters Living Work. So basically, Sister Living Work is an NGO which is engaged in suicide prevention awareness program, which is done by raising community involvement and educating them. Uh, it has been it has been uh, it has been ultimately visualized as what we visualize is an ultimate suicide free India is what we look at, and to sensitize each person and make them aware the importance of mental health. And so what do we intend to do? So we intend to do is like developing education content to promote awareness about suicide and mental health, and delivering them through offline and online mediums such as workshops, conference, and multimedia outlets. Now, talking about how did it started, the Sister Living Work was born after the founder Gayatri Datta lost her family member to suicide. Her experience, the pain and grief is caused her. She pledged to work for the cause to create awareness and. Uh, so this is how, like, I mean, this is our founder, this is how she had formed this particular NGO, and we have started working toward. And what else we do here is like basically we do workshops, we do support groups, we do training course, and recently we have also launched our counselors training for training counselors for education institute or schools and like that. So coming to workshop, what we do at workshop is our workshops aims to build awareness on suicide preventions, warning signs, myth, and the role of a first responder. It equips the participants to act as a first responder to someone in a suicide crisis. Our workshop encourages experimental sharing, providing a safe space for people to share their stories, experiences, and thoughts. The workshops are tailored to meet the needs of the groups. In the light of the pandemic, the need for suicide prevention training has increased. I mean, as we all know. So since January, we have been able to touch around 2,500 through our workshops. Uh, and some of the organizations that we have also collaborated with, like while doing these workshops, are IIT Kanpur, USF, that is Udayan Shalini Fellowship, then the Vellore Institute of Technology, and so that's how. And coming to support group, what we do at support group is our support groups are conducted twice a month for emotional distress and for survivors of suicide loss. In the last 2 months, we have seen new members accessing these space. Considering the effect of the pandemic on mental well-being, these groups act as a safe space to share and process emotion related to loss. Then coming to training courses that which we have recently launched for counselors and educators. In July, that was last July, we commenced with our training course on suicide prevention awareness for educators and school counselors. The training is based on a manual developed by the organization. Many schools in India do not have school counselors. Consequently, they are not well equipped to deal with instances of suicide and self-harm. Basing our work on the World Health Organization multi-sectoral approach to suicide prevention, the training course aims to initiate this process with educational space. The course aims to equip counselors, educators, and individuals working with school children with the necessary skills and knowledge to understand risk factors associated with children, in addition to learning about protocol to undertake if a child is engaging in self-harm, suicidal kind of behavior, or if a suicide has taken place. The course aims to enrich our understanding of how to make educational space safer such that it encourages help-seeking behavior among students and build awareness about suicide prevention. So these are the three major programs that we have been running as of now. Uh, Moving forward, we are also, we are also holding our conference coming, which is supposed to be held on 11th and 12th September. Again, we have the way you guys are doing, it's a 2 days conference with workshop and with speakers, eminent speakers coming over. I think from here I'll ask Sachi to take charge and take over to throw more light on what the work that we have been done so far.
Thank you so much, Meenakshi. I hope I'm audible. Yeah. So as Meenakshi mentioned that at Sisters Living Works, we do conduct workshops on suicide prevention awareness. And oftentimes when we approach organizations to conduct a session, there's a sense of discomfort and concern surrounding the topic. So we do get questions like, will this encourage people to think about suicide? Don't you think it's too negative a topic to conduct a session on? Can you reframe the title of the session to something which is more positive? And we're still very hesitant to openly talk about a subject that requires our immediate attention. Almost all countries at this point in time are facing an increasing number of suicides. Suicide is one of the 10th leading causes of death in the world. Now, this kind of hesitation has a lot to do with the ideas that we have about suicide, ideas that we grew up listening to, what we heard around us. And a lot of these beliefs are misconceptions and myths. And holding on to them only means that the topic continues to remain stigmatized. People don't want to talk about it. And this makes it only all the more difficult for individuals who are struggling with suicidal thoughts, people who have previously attempted suicide, individuals who've lost a loved one to suicide. And through our workshops, we intend to educate people on the prevalence of suicide. We debunk myths and misconceptions and teach them about the warning signs. Most importantly, emphasize on the fact that suicide is preventable. It is one of the most preventable forms of death. But what we need to understand is that there are warning signs. There are certain steps that we can take to support someone who might be struggling. So what we really need at this point in time is to have more conversations on the topic, not just today, not just in the month of September, something that we continue to have. At SLW, we also conduct support groups for survivors of suicide loss, and that forms a very important component of the work that we do. Now, why is it important to address this group of individuals, people who have lost a loved one to suicide? So studies have shown that survivors of suicide loss are at a higher risk for suicidal ideation. Now, to understand this better, it's important to look at the kind of grief a person experiences on losing a loved one to suicide. Now, there is sadness, there is anger at the actions of their loved one. There are feelings of regret, guilt at not doing enough. A lot of survivors attach a sense of personal responsibility to the loss. Many times they spend a lot of times, pondering over the why. Why did this happen? Could they have not just, spoken to me? Or could I have done something to save my loved one? So it's a very difficult space to be in. But now, because there's a lot of stigma attached to suicide, it becomes very difficult for them to openly talk about their grief. Either people around them might be hesitant to bring up the topic. Sometimes because of this stigmatization, a person might find it very hard to openly admit that they lost a loved one to suicide. Maybe specific instances like when a parent loses a child to suicide, there's this universal assumption that parents are responsible for their child's actions. And because of that, a lot of parents might struggle to come to terms with their loss. There's a lot of personal responsibility attached to it. And because of the stigmatization, survivors of loss often don't have enough opportunities to openly talk about their grief. We've had instances where survivors have spoken about how they struggle with certain emotions. So when we think about grief, generally what comes to mind is that there's sadness, a person is crying. But what we tend to ignore is that there are so many other aspects to that grief. We've had survivors talk about how for a long period of time they felt angry at what their loved one had done. And when they experienced anger, they felt they shouldn't be feeling this way. It was not okay to be angry at someone they have just lost. But the point is that is also a part of their grieving process. So that's essentially what we do at SLW is we conduct these support groups with an aim to hold space for people who have lost a loved one so that survivors of loss can come together. They can openly and freely share about their loss, learn from one another, understand that they might be at very different stages in their grieving process, but it's okay. to talk about it, to discuss openly about it. The lack of communication can often be very detrimental when it comes to working through their grief. So this is another thing that we do at SLW, where we do work with survivors of loss, focusing on their needs. Now, a little bit about suicide prevention. Now, oftentimes when we think about suicide, we see it from just the mental health perspective. That is important, but it's not enough. Suicide is not just a mental health problem. It is a public health concern, and it is a matter of social justice. When we only look at it from a mental health perspective, what we're then implying is that if we have to bring about a change in the situation around us, that only depends on the mental health care system, and that is only possible for people who have access to these resources. And we understand that not everyone has access to mental health care services. Even if people might be able to access it, they may not have the funds to afford them. So we have to adopt a broader perspective when it comes to looking at suicide prevention. Suicide is a very complex phenomenon, which is a result of an interaction between components that exist at the individual level, when it comes to relationships, at the community level, or at the society level. And suicide can affect everyone, but some individuals or certain groups might be more impacted than others. They might be at a greater risk. And this is something that we need to become more aware of, because despite the work that is happening, people still continue to see suicide as a very personal, as a very individual issue. So many times when a person may have attempted suicide, there is this general notion that is a sign of a personal failure, an act of cowardice, a very selfish action to take. So a lot of personal blame again is attached to the situation, and we tend to ignore or invalidate the possible factors that exist in the person's environment, which may sometimes be beyond their control, which might be contributing to how they are feeling. So we need to adopt a more broader perspective when we look at suicide and suicide prevention. There are societal injustices which exist, which do contribute to how a person might be feeling and how their mental health has been impacted. So it's important that we don't look at it as just as an individual matter, because suicide prevention at the end of the day requires collective efforts from each one of us. I know majority of you all over here are students of psychology, but the point is, it just does not depend on people who are within the field. Each one of us has a role to play. Even when the World Health Organization talks about suicide prevention, they talk about a multidimensional approach. Efforts from the government, efforts from organizations, whether that's the college level, the school level, workplaces. And that's something that we are also working towards at Sisters Living Works through our recent program, where we are working within schools with counselors and educators to initiate suicide prevention programs. So the point is, it requires each one of us to make an effort. Now, at the individual level, what is it that I can possibly do? I think the first step is to educate ourselves on the topic. All of us have ideas about suicide, ideas that we've read about, we've grown up listening to. It's important to reflect on whether these beliefs and ideas are sometimes misconceptions and myths, because that is a major hindrance when it comes to suicide prevention. So if I am to talk about a few very common myths that exist, about suicides. So one of the most common myths that people have is that talking about suicide with someone, especially adolescents, will plant the idea of suicide in their mind. The reason people are scared to talk about the subject or even bring it up is because there's a fear that it'll create an idea. But studies have shown that talking about suicide does not create, neither does it increase the risk of suicide. It actually creates a window to have a two-way communication. When we talk about the subject to, say, adolescents, we are in a way giving them correct information, because online you have easy access to a lot of wrong, inappropriate data. So it's important to have more open conversations. If you feel that someone might be struggling with suicidal thoughts, someone might be contemplating, it's important you ask them and not be scared about asking them, because for all you know, they might just want to talk about it. And maybe you reaching out, you asking them that, hi, I've been concerned about how you've been feeling lately. Is this something that you've been thinking about? It's okay to do that. The second and very common myth that people have is a person threatening about suicide is not serious about completing suicide. They might just want attention. A lot of times people say that, if a person has spoken about suicide, this is just attention seeking behavior. The point is, talking about suicide is a cry for help. A lot of people who are thinking about suicide, people who've attempted suicide, for them, this is a way to escape the pain and despair that they're going through. There will be instances, one or two, where a person might use suicide as a means to maybe, manipulate the situation. But that still indicates that they require help, right? So any conversation, if a person is talking to you, has opened up to you about hurting themselves, about harming themselves, it's important you continue to support them and encourage them to get help, and not dismiss them by saying that this is just drama or attention seeking behavior. Another very common myth that people have is that once someone is suicidal, they will always remain suicidal. Now, heightened suicide risk is often short term and very situation specific. Suicidal thoughts can return, but they're not permanent. Even individuals who've had suicidal thoughts previously can go on to lead very, absolutely, can actually work towards, if they get the right kind of help and intervention, they can be trained to take care of themselves and work through it. What's very important is that they get the right kind of help, support, and treatment as soon as they start feeling that way. And another very common myth is that suicides cannot be prevented. A person who wants to die by suicide will try to do it. The point is, suicide is one of the most preventable forms of death, and individuals seek out help in some way or the other. And one of the most important factors when it comes to preventing a suicide is the presence of a support system. And the keys to prevent are recognizing what the possible signs are, knowing what you can possibly do to help them, talking, listening. These are very basic actions, but they can go a long way in a situation like this. And that can really help you take the person away from any kind of, distract them from these self-destructive thoughts until any other form of assistance can be provided. So the point is, support is very essential. It's important for us to even reflect on our own actions as individuals. Are we able to hold space or provide that kind of support to people around us? Are we dismissive when someone opens up to us about something like, feeling this way or hurting themselves? Being able to reflect on our actions, reflect on our ideas about suicide. There are opportunities to engage in gatekeeper trainings and other such courses, which actually help you to understand how you can support someone who might be in, how to respond to someone in a suicide crisis. This is something that we also do at Sisters Living Works. So these are a few basic points that I really wanted to touch upon in today's session. So the point is that each one of us has a role to play. Even the smallest of actions can go a long way. Just being there, being ready to listen to someone, offering them your support, encouraging them to seek help, providing them with resources that you can in terms of helplines they can call or centers they can access, can actually have a big role to play. So with that, I would like to end our session. Thank you so much for having us. And in case you all would like to reach out to us, you can contact us.
Thank you so much, ma'am. That was absolutely enlightening, and I think our students have understood, what the whole idea of, your periphery, your work. Ma'am, there is a question from one of the students, if I can take the question. Apparently, in our country, consulting a mental health professional or going for psychotherapy is considered to be a big tension and embarrassing, also given less importance. How can we change the mindset of people who think like this?
Right. I think it's a very important question, and something which I think a lot of people, we've come across this many times, wherein going to a mental health professional, there's still a lot of stigma attached to it. There is this idea that, because of course there are so many wrong notions about seeking help. I think the way forward is to be able to have as many conversations as you can, within your homes, within your communities, with your friends, with your families, being able to talk to them about why this what it is, why it's absolutely okay and absolutely normal to seek help or go to a therapist. Sometimes people feel that if you need to go to a mental health professional, you need to have a severe mental health condition to approach someone. But the point is, you can go for therapy, you can seek these services, even if you may not have something very severe or distressing. People go to therapy for different reasons. So I think the way forward is to have these conversations with people around you. And I think that is the way that we can really, work towards changing this kind of a mindset.
Thank you, Sachi. Sachi, there's another question.
Yeah.
That do you really think that talking on a helpline or reaching out to a psychologist will really help?
So definitely in terms of what we've often come across and what we have heard. So we on a helpline, but we do have people who come to our support groups and have shared their experiences of reaching out to helplines. And the point is, many times it works for a lot of people. For example, I do know about someone who shared how calling a helpline at night actually helped them because they were in a lot of distress. So that works out for people because it either helps you when a person is generally experiencing a lot of distress. It's very hard to think straight. And especially when you're thinking about hurting yourself, harming yourself, it's very difficult to think of an alternative to your situation. This is something that we often call a tunnel vision, where it's very hard to see that there are alternatives to your situation because it almost feels like there's a dead end. There's no way out of this. So at that point in time, calling up a helpline, speaking to someone else can actually help you, navigate through that space. So it definitely has worked, and it is something that, I would encourage people to do.
Thank you, Sachi. I think today we've had two awesome, organizations putting up their great work, absolutely from passionate, eminent speakers. One from Sisters Living Works, and we had also a speaker from iCall. And I think we have made this small contribution to create awareness in students that, you have the mobile, you have the numbers, you have the emails, and a lot of other clinical psychologists, psychiatrists have spoken that it's okay absolutely to reach out, and that's the only way you can break the stigma, by reaching out. And I think from all our speakers, we've got this common, hope line that, like you mentioned, that hope is very important, and there is, solutions on the other side, and we can get it when we reach out. So thank you once again, Sachi. This was really nice, and thank you for accepting our invite. And I think you've already put the email down, so students, we can get it once again from the chat box. I would request everyone here to make a note of it. It's going to be really helpful. And thank you once again. Over to you, Gargi.
Thank you so much, ma'am. I would like to take a minute to thank Meenakshi ma'am and Sachi ma'am for such a valuable insight. Thank you for taking the time to speak to us today on the very important topics of suicide prevention and subsequent education and sensitization. Elaborating on the inspirational efforts of Sisters Living Works, you brought to attention that undoubtedly suicide is a complicated phenomenon. However, you very rightly stated that it is one of the most preventable causes of death. Hence, the need to destigmatize and provide a way for survivors and families that are grieving those that they may have unfortunately lost to suicide to connect with resources and support groups where they can receive help with no judgment has become all the more necessary. I once heard that we live in a society because we need each other. People need people. And today you have shown us ways in which we can play a part in providing a safety net, providing social support for someone in need. It has been a great pleasure to have the both of you here with us. Thank you so much once again. Over to you, Takreem.
Thank you so much, Gargi. As we come to the end of our webinar, I would like to propose a formal vote of thanks. I wholeheartedly thank all our respected honorable speakers for taking time out from their busy schedules and enlightening us on the various resources, topics that are essential to understanding crisis prevention and dealing with an issue as serious and often as stigmatized and complicated as suicide. On behalf of the Department of Psychology, RD and SH National College, and SWA Science College, I would like to thank our collaborating organizations, WICCI Public Service Council Maharashtra and the Department of Psychology at SNDT University affiliated Maniben Nanavati Women's College for their support and contribution in making this webinar a grand success. I would especially like to thank our wonderful audience for attending this session in such overwhelmingly large numbers on both Zoom and YouTube platforms, and hope that this has been an excellent learning opportunity for all those present. I would like to close this webinar by saying that when you don't have the strength to take another step, ask those you love to pull you. Reaching out is not an act of cowardice, but one of the greatest steps of courage. It isn't weak to ask for help. It's like using a flashlight when you're lost in the dark. I would like to quote the New York Times best-selling author of If You Feel Too Much. This life, your story, your pain, your hope, it matters. All of it matters. To our friends, family members, co-workers, neighbors, and even strangers, we want another day with you. Lastly, I request all of you to fill the feedback forms, the links of which have been shared in the chat box and WhatsApp groups. The certificates will be handed over to you in a week's time after you fill the feedback forms. Once again, I thank everyone for their enthusiastic participation and making our guest speakers feel extremely welcomed. We hope all of you had a wonderful day, and we hope to see you all again with another webinar very soon. Until then, stay safe, take care, and spread love. Thank you so much.
Thank you to the entire Maniben Nanavati Women's College team. Excellent job in every small endeavor that we have all worked together. Excellent teamwork. Thank you to National College Department of Psychology team for putting in so much of hard work. The TY Psychology group, you all rock. Thank you once again to all participants for being so patient and being so cooperative. Excellent questions in the chat box. Thank you guys. Happy Ganesh Chaturthi tomorrow and stay safe, be safe. Thank you.